You are live now, sir.
So, can we start?
I think we can start now.
Dr. Balla, sir?
Hanji. So, we are going to start our, am I audible?
Yeah.
Okay. So today we are going to start the global web series of DOS, and this is dedicated to the subspecialty of squint. We have lined up excellent national and international speakers. This program has been prepared by Professor Subhash Dadia and Professor Rohit Saxena. We have speakers like Dr. Deepti Joshi, Dr. Amilade Elvis, Dr. Savleen Kaur, Professor P.K. Pandey, my teacher, Professor Rohit Saxena, Professor Pradeep Sharma, Professor Subhash Dadia, and of course our international speaker of today, Professor Sehan Ozcan. So I think without much ado, we'll start the proceedings of today, and I hand over to Professor Subhash Dadia to introduce our international speaker of the day, Professor Sehan Ozcan. Dr. Subhash, please.
Thank you, Dr. Balla, sir. So, at the outset, I would like to thank each one of you for joining this web series. So, Dr. Sehan is graduated from University Medical School, Ankara, and she has been trained in subspecialty of the strabismus in Moorfield Eye Hospital, London. She is professor of ophthalmology at Andaman Maintenance University Medical School, and she has around 130 published papers, 10 book chapters, and she has edited 2 ISA transactions. She has been local organizing secretary of meeting of European Strabismus Association and International Strabismus Association. She has been invited speaker at around 230 international and 70 national conferences. And she is past president of Strabismological Society of Turkish Ophthalmic Association. She is past president of ESA, and she is past president of ISA. She is happily married and have 2 children. And it is over to you, Dr. Sehan, for your topic.
Thank you for this very kind introduction. And I try to make share screen. And do you see my slide? I cannot see my slide now.
No, not visible.
Not yet.
Not at the moment.
We cannot see your slides.
Okay. Let me try again.
Yeah, they are visible.
We can see your slides now.
Yes, but when I do it full screen, I lose my slide. So on the test drive, we did not face any problems. So could the technical team help me?
Yeah, Bagesh, look into the problem.
Yes, ma'am.
Just see when
Yeah, so I make
screen.
my share screen, but when I click on full screen, and it goes away. Well, on the test drive, we did not face with any problems. So you see, when I click on full screen, it goes. How can we solve this?
Click again. Was there a vacant slide? I mean, just in the slides a little.
Yes, but let's try this one. No, it goes out. So I'm going to close it in total and start again.
Could we start with Dr. Deepti in the meantime, so that Bhageshwar can help you to figure out the issues?
Yes, of
But
course.
let's try it once. Now that you've
Yeah,
tried it,
let
let's give
me
it one
do
more
The
shot.
slides
One
are
more
visible.
try.
Yeah. Let's give.
Dr. Sehan,
Do you see my slide now?
We
Yeah,
do.
they are visible.
Yeah.
Great.
It is slideshow. It is
Yeah.
slideshow.
Is it okay now?
It's
Yes,
okay now.
please go ahead.
Absolutely okay. You can start.
Okay, all right. Well, I'm really surprised to see this slide because I have no idea what happened. Anyway, so dear moderators, Professor Sapesh Ladea, Professor Rohit Saxena, and friends from India, it's my distinct pleasure and honor to participate this DOS webinar, and I'd like to thank for this kind invitation to Professor Sapesh Ladea. So I'm sorry for the technical problem at the beginning. So I'm going to talk about the superior rectus weakening and superior oblique palsy. So in long-term superior oblique palsy, superior rectus contracture may develop, and it may end up with superior rectus contracture syndrome. So this name was given by Jampolsky and Scott. So the clinical characteristics of this problem is a large hypertropia with limitation of depression in all down gaze and hypertropia in all up gaze, a pseudo overaction of the contralateral superior oblique, and a large difference in Bilshowski head tilt test, a large vertical fusional amplitudes, and it is often associated with a positive forced action test. So when we look at the incidence in diagnosis and in surgery is quite similar, and it is in between 11 to 22%. And you can see that the least incidence is from our series. This is maybe because we use more strict criteria to make this diagnosis. So when we look at the etiology, Jampolsky and Scott claimed manifestation of hypertropia in the absence of fusion as the etiological factor, and they recommended superior rectus recession for treatment of this problem. And later, Rensan-Paris proposed that this is an attempt to compensate excyclotropia, so the treatment should address correction of excyclotorsion. This is somehow a little bit supported by the findings of Irene Ludwig. So when we look at the indications, the first indication is the need of two muscle surgery in the absence of superior oblique tendon laxity or the absence of superior oblique tendon. But the must characteristics are large vertical deviation exceeding 15 diopters, clinical findings suggesting superior rectus contracture, and a positive forced action test. So the forced action test should be done without any retropulsion. And the forced action test is not severely positive in those as it is there's an increased active generated force. So we reported a group of patients with superior rectus contracture syndrome in long-term superior oblique palsy. Our series included 15 cases out of 145 operations. And in all of the patients, superior rectus recession was performed in combination with inferior oblique disinsertion. And the mean follow-up was 34 months. And the primary position deviation was 23 prism diopters, and the difference in Bilshowski head tilt test was 16. And adjustable recessions were performed in all adult cases, and the superior rectus recession was done 4.8 millimeters. This is a mean number, but this is not very precise as we mostly do adjustable recessions. So when we look at the results, in 80% of the cases, the results were quite satisfactory. In 3 patients, which represent 20% of our cases, there was an overcorrection despite adjustable surgery. In 2 of these overcorrections, ipsilateral inferior rectus botulinum toxin injection gave satisfactory result, and 1 patient underwent further surgery, and this patient was accepted as masked bilaterality. And this is one of our patients in this series. This gentleman has a right superior oblique palsy with a large deviation, and you see the limitation of depression here. And following superior rectus recession and right inferior oblique disinsertion, the result was quite satisfactory. You see the pre and postoperative Bilshowski head tilt test. And this is another lady. This lady has masked bilateral supraoblique palsy, more in the left side, and she has severe torsional problems as well. So in this patient, left superior rectus recession, left inferior oblique disinsertion, and bilateral Harada-Ito surgery was performed. And this is the end of the surgery. And the result was quite satisfactory. You see the pre and postoperative Bischofsky head tilt test. And this is another lady who reported some problems, and this is one of our overcorrected cases. This lady had no problems during adjustment. However, 1 month later, she came back with consecutive hypotropia in the left eye. So at this stage, during this acute period, we have injected toxin into the left inferior rectus muscle. This is 1 week after toxin injection. You see the underaction in the inferior rectus muscle. And this is 4 years after toxin injection. So the result was permanent. She did not require any further treatment. So when we look at the previous literature results, so the results are quite variable. So when we look at the success rate, well, it can be 100% or as low as 17%. In our cases, the success rate was 80%. And the overcorrection rate is, again, many authors did not report any overcorrection, whereas some authors reported overcorrection as high as 50%, whereas in our series it was 20%. So why the variability is so much? Because the patient selection criteria in those series are not uniform. And in some of those, some authors use superior rectus recession as the only surgery, or the surgery was combined with a number of different procedures. And however, in our series, we have concluded that superior rectus recession in combination with inferior oblique disinsertion is an effective surgery for the ones who have superior rectus contracture. However, the risk of overcorrection should be considered. So what are the pairs for a successful outcome? First, the minimum superior rectus recession enough to resolve forced action test should be chosen. Superior rectus recession should not be considered with any inferior oblique anterior position surgery because it will end up with anti-elevation bias. That will mean weakening 2 elevators. And in those who had torsional diplopia, a torsional surgery should be addressed and on separately. And superior rectus recession only should not be considered because there will be a risk for increased excyclotorsion. So the preventive measures for overcorrection are where the first is small undercorrection should be aimed. Adjustable surgery seems more advantageous. Kushner proposed disinsertion of nasal 3/4 of the superior rectus muscle. And we have also proposed weakening of superior rectus muscle by botulinum toxin injection, or as some others propose, not to do any superior rectus weakening, just to go on with torsional surgery. But I must say that in our hands, the result is not as was reported. So we always had residual problems in those that we tried this solution. So we reported a small group where we have chosen toxin injection into the superior rectus muscle instead of a recession. Our small series included just 3 patients. And we have concluded that it was a safe and effective alternative. And this is one of our cases who had a large vertical deviation in the right eye. And he received toxin into the right superior rectus in combination with inferior oblique disinsertion. This is postoperative 1st month. So as expected, he had right ptosis. And this is post-op 1 year. The result was quite satisfactory and stable. So the take-home messages are: superior rectus recession plus inferior oblique disinsertion is effective in superior oblique palsy with superior rectus contracture in selected cases. Torsional diplopia should be addressed additionally. And there's a risk of overcorrection despite adjustable surgery. And inferior rectus botulinum toxin injection is very effective to resolve overcorrections when it is performed during the acute period. And superior rectus botulinum toxin injection may be an alternative method instead of recession if superior rectus contracture is not severe. I'd like to thank you for your attention, and I'd be glad if you have any questions. Thank you.
Thank you, Dr. Seyhan, for excellent presentation. Dr. Alkesh and Dr. Prasad, our treasurer and president, has also joined. So, Dr. Prasad, sir.
Can I ask one question, Dr. Subhash? Dr.
Good
Subhash,
evening.
can I, Dr. Subhash, can I ask one question?
Sir, we will
Yes.
take questions. Let the president and treasurer.
Just a minute, yeah. Dr. Rajendra Prasad, our president.
Good
Just say
evening
a few
and
words.
good evening to all of you, and it's so pleasure to see you all up here in this beautiful and wonderful meeting, which is planned by Dr. Subhash Dadia. And we have such a great speaker, Dr. Rohit, and all Dr. Oskan, and so many people here I see, and it's really happy to see you all here. And I hope this session is going to be very interesting and wonderful to our guests, those who have joined here. So thank you. We'll continue with this session, and Dr. Subhash, you can continue with the question answer session. Yeah.
Dr. Alkesh, you want to say something?
Yeah, I heard the session from Dr. Sehan from Istanbul. It was really excellent. And of course, the Indian faculty is great faculty doing a great job in Squint. I think it would be great discussion. Will be adding to our knowledge. I think it will be great thing. Thank you. I think we can go ahead with the question answer.
Dr. Pandey, sir, you wanted to ask something?
Yeah, I wanted to say one thing, that most of these cases will have a lot of extortion also, and a good number of these are congenital superior oblique palsies, which where the tendon is going to be rather lax or absent. So if we transpose this SR, one is that recession is going to add to the extortion. So if we do a lateral transposition, temporal transposition, that may help extortion a bit. And in fact, that's what was done by Jackson in 1903. That is the first surgery for the superior oblique palsy, which was done by Jackson.
So you mean transposing the superior rectus muscle?
Temporally, that will help extortion a bit of because there's a lot of extortion, and it's going to, in acquired cases, it's of course a very difficult situation, and in congenital also it's going to sort of disrupt fusion if there's a lot of extortion. So if we are able to reduce that extortion a bit, that will probably be better in both these situations.
Yes, yeah. Well, this is of course a good idea. However, I must say that when we do it on adjustables, I'm not quite sure how much when we transpose it and when we do it on adjustables, where the muscle stays is a little bit of under discussion, I must say. So that's why in those who had torsional problems, as I've demonstrated during my presentations, I prefer to go on Harada Ito surgery, where I'm more familiar with the effect that I'm going to have it. And I must say that in none of our patients we did not face with any problems with the torsion. The problem that we have faced was the ones that as I've showed, some elevation deficiency at the beginning, and which was resolved afterwards. And the only patients that we had to reoperate was the one who had mask bilaterality. And so regarding the torsional surgery only, because as the time was quite short, I passed it very briefly, as Vincent Paris proposed, that if you correct torsion, you can eliminate the vertical deviation. Well, in true superior rectus contractures, I don't think it is possible, because in some cases that has a little bit of contracture, I've tried just to go on with the other surgery, but the remaining deviation never disappears in those who had true superior rectus contracture. Luckily, these cases are not so frequent. We don't see them so frequently, but when it is there, I think weakening the superior rectus works quite well in this relatively regular patient.
Yeah, thank you, Dr. Subhash. I just wanted, Dr. Sian, two questions. One, what is your dosing for the superior rectus? And also, if the FDT is tight preoperatively, would there still be some residual hypertropia in the depression gaze? So that would maybe not relieve a moderately tight superior rectus. So,
first of all, the mean amount in our patients was 4.8, but this is not a precise number. So, well, generally speaking, it is around 4. But in some of the cases that there were a few cases who had really very tight muscles. So I had to release the muscle more. But as it was always on adjustables, the numbers are not very precise. It is just by some little guesses. So I cannot give you a table number that.
Dr. Sehan, I was asking for the Botox, for the botulinum toxin, the dose for botulinum toxin.
Oh, sorry. I'm sorry. I understood as it was the surgical dose. Well, for the toxin, it was 5 units, okay, as I always use. So 5 units. I don't want to give a higher dose because of the ptosis problem. And in those cases, I normally never open the conjunctiva for injecting botulinum toxin. But in those cases, I make a very small cut as I'm already in the surgery, and I don't go far back. So the injection is done in a more anterior point in order to avoid very severe ptosis problem. And it was always 5 units.
Thank you.
Dr. Sehan, why do you prefer disinsertion as compared to the recession?
I must say that, first of all, I'm very happy with the results. And on the other hand, why I prefer this insertion from the beginning is because of my mentor's choice, I must say. So when I was in Moorfields Eye Hospital, I was studying both with John Lee and Peter Fels. And Peter Fels was doing recessions always, and John Lee was doing disinsertions always. So when I was there, they had a very large series, so they compared and their results were exactly the same. And it was John Lee's phrase that he always was telling that he was drinking coffee when Peter was suturing the conjunctiva. So inferior oblique disinsertion is a very effective surgery when it is done properly. So the residual inferior oblique problem is almost always because of some residual tiny bands and so on. And so the problem is that. So it's a very good self-adjusting surgery. I only suture the muscle when I need some anterior position effect, or if I consider that there may be some DVD problem and if I can need this muscle further afterwards, then I prefer a recession. And I prefer anterior positions in all DVDs. And but for superior oblique palsies and in other cases that inferior oblique weakening is required, my preference is always this insertion. It works so well. We have reported a large series. Actually, it was in a transactions, but I think we need to publish this because this insertion is in most of the literature. It is said as it's not as efficient as recession, but it is not the case in our hands as well as it was not the case in my mentor John Lee's hands.
All right.
Thank you. Dr. Pradeep Sharma sir has joined. Welcome, sir. Sir, would you like to offer some comments? You are muted, sir.
I
Sir,
joined
unmute
late. I joined late, so I don't know exactly which part you want the comments on. So, yeah.
Disinsertion, inferior oblique disinsertion versus recession. So that's what Dr. Sehan was mentioning, that she prefers disinsertion except under certain circumstances. So,
I think in inferior oblique, there are people who do disinsertion, there are people who do myectomies, people who do recessions. I have always been propagating a surgery which I say that razor with an eraser. You should do a surgery which is able to be changed if you want to. If you are doing a disinsertion, it's like, the old times when even for the horizontal recti, people were doing disinsertions and they were very happy. So, I mean, in today's time, I would say you should do a quantifiable surgery, which can be undone or changed. So if you do a recession, yes, it does take a little more extra time, as Dr. Shehan was saying, for suturing, but that's what sutures are meant for. And I think you want a tailored surgery, which can be undone or redone. So that's always possible. So like what she said, that when she wants an anterior positioning effect, she does. I personally feel that inferior oblique is a procedure in which you can do the weakening as per the requirement. If you have a 1+, 2+, 3+, 4+ overaction, you can do accordingly. The various weakening procedures are available, from Finks to Parks to the modified Elliott and Nankin, and to the total anterior nasal transpositioning, which gives you very well results. So to each one his own or her own.
So I don't think
Just,
never be
may I
resolved.
make a small comment? Of course, I mean, these are, of course, very points that is highly appreciated. And but the thing is,
Basically, it is surgeon's choice.
Yeah.
yeah, but just the thing which is curious is, first of all, when you do a disinsertion, you will be able to find the muscle if you need. But what seems so curious to me, people, I mean, well, we say it as surgeon's choice, but many surgeons choose myectomies, which is actually, from my point of view, which is a surgery that should never be done, because as you mentioned, inferior oblique is a muscle that you may need at any time. Because of trauma, you may lose the inferior rectus, and you may need to the inferior oblique in order to have a depression effect or something. So myectomy seems so, it is the last choice from my point of view. But the curious thing is, many people make the choice either recession or myectomy. Myectomy is a very popular surgery. I don't know why.
I think because it's easy for people to do, but
disinsertion is also
but
easy.
if there is a
even
problem,
easy.
that's what I'm saying. Easy things are not the best things always. We should do a procedure which can be redone or undone by any other surgeon also. So I have got cases in which myectomy has been done and they still have overaction, and it's a tough thing to do after as a second procedure. So I feel recessions or anterior positionings in which we have a muscle at the point that has been stitched, we can always undo it, redo it, and improve the situation. So it's more quantifiable approach.
Thank you, sir. I think we should move to the next speaker. Thank you, Dr. Shehan, for an excellent presentation, and thank you everyone for nice discussion. Dr. Bhalla, sir.
Yeah, I think now we go on to the next speaker after a wonderful talk by Professor Shehan. And the next speaker is Dr. Deepti. I'll just give her brief introduction. Yeah. Dr. Deepti Joshi is a pediatric ophthalmologist at MM Joshi Eye Institute, Hubli. She is actively involved in PG teaching for the past 8 years. And she is recipient of Best Squint Paper Award at AIUS and Best Squint Video at World Society of Pediatric Ophthalmology and Strabismus. She has multiple publications in national and international peer-reviewed journals. Beyond ophthalmology, she is enrolled in LIMCA Book of World Records for training maximum teachers at a stretch about safeguarding children against child sexual abuse. Over to you, Dr. Deepti. Stage is all yours.
Are my slides visible?
Yeah, they are visible.
Just a minute. So at the outset, I would like to thank Subhash Dadia sir, Bhalla sir, and Rohit Saxena sir for this wonderful opportunity. Good evening, Pradeep Sharma sir. So I would like to start my talk, which is on strabismus evaluation and management. So as in any case which is seen in ophthalmology, we always proceed stepwise when we are assessing a case of strabismus. The first would be history. Second would be visual acuity and cycloplegic refraction. Third would be the actual evaluation of the strabismus, and that is sensory followed by motor evaluation. So what are we trying to do? We are trying to find out if there is any amblyopia, what is the binocular status of the patient, and to find out the type and the amount of deviation. So as I already mentioned, the first step is history. Few questions very much pertaining to strabismus, and that would be about the deviation. Since when is it? Is it constant, intermittent? Has it been progressive? Is there any associated diminution of vision, diplopia, or any asthenopic symptoms? Cosmetically, has the patient noticed any abnormal head posture or palpebral fissure changes? Some questions which are not exactly pertaining to strabismus, but may be predisposing factors, like is there any family history of squint or glassware? Personal history, is the child premature? Any history of seizures or the previous history of fever which has been predisposing to that of the strabismus. The next step would be vision assessment. We all know that amblyopia is one factor which really determines the management of the strabismus. So the age appropriate vision assessment, right, ranging from fixation pattern to preferential looking tests like Teller Acuity Card, Cardiffs, or in the slightly older children, picture charts like Lia symbol chart, HOTV chart, and finally the letter chart, which may be either Snellen's or the Logmar chart. Refraction plays a very important role, as we know that the two most important factors like accommodation and the AC by A ratio maintains or controls our strabismus to a large extent, and it guides the way we manage it. Atropine is gold standard in the in cycloplegic refraction, but may not be possible all the time, especially in school going children. Homatropine in those children gives as good result as that of atropine. So once we assess the cycloplegic, assess the vision, once we give the accurate glasses to the child, the glasses has to be given as far as possible after performing a retinoscope. It is mandatory for every strabismologist to know retinoscopy perfectly. So then with the glasses on, with the perfect vision, we go ahead with the sensory evaluation. Sensory evaluation is always done before the disruption of the fusion, which could happen with cover uncover tests in the motor evaluation. So what is the aim? We assess what is the grade of binocular single vision, and we find out if there is any sensory anomalies, is there any diplopia, is there any suppression, is there any abnormal retinal correspondence in this patient secondary to that of the strabismus. Stereo acuity test is the foremost test in the sensory evaluation. Qualitatively, Lang pencil test is there, but then least used. Quantitative tests, which are most commonly used, can use dissociative glasses like red-green glasses or Polaroid glasses. The most common one are based on the Randot and the TNO tests. But the ones which not requiring glasses are Frisbee and the Lang, where the dissociative factor is present within that of the 3D factor is present within the test itself. The most commonly done sensory test is Worth 4-dot or the Bagolini test, though there are multiple tests which are based on the diplopia principle or on haploscopic principle. In Worth 4-dot test, remember to do it both for distance and near. The near Worth 4-dot torch is available. The distance Worth 4-dot test is incorporated within our vision charts. We all know that there are 4 colors and patient wears the red-green glasses, and we ask the interpretation as to how many colors or how many circles he sees and what are the colors. The most important factor in the Worth 4-dot test is the differentiation of the microtropia. This is one which we usually miss even when we do a motor evaluation. Despite doing a perfect 4-diopter base or prism, many fellows end up missing this condition. So in the Worth 4-dot test, when there is a disparity between distance and the near, when you see 4 dots at the distance, but at the near, or at the distance, the patient says either eye suppression, that could indicate the presence of microtropia. So now that we know what is the sensory status of the patient, we go ahead with the last step, that is motor examination. This is divided into 5 questions. First one, is there a strabismus? If yes, what is the type of the strabismus? Now that you know what is the type of the strabismus, what is the amount of the deviation, because the next would be correction factor. What's the ocular movements? And based on the abnormal ocular movements, if we detect any special test which we need to do. So first question, is there a strabismus? For this, the most common test which we use is the light test, the Hirschberg test. So the central alignment of the Hirschberg test indicates no presence of no strabismus. Pseudostrabismus can be ruled out by this condition. It can even measure the amount of deviation, but it's not used ideally as a gold standard for measuring the amount of deviation. Once the child walks in, before you do a direct light reflex test or the Hirschberg test, it's important to rule out any abnormal head posture. Could be face turn, could be chin, the head tilt, or could be chin lift. So we need to correct the abnormal head posture before proceeding into any of the further tests. They can be measured using the goniometers also. So once we find out there is a squint, if it's a pseudo squint, well, the work is done. But if there is a squint, now we have to confirm what is the type of the deviation. And that is the cover test. For all the postgraduates or the general ophthalmologist, the first thing they end up doing is an alternate cover test. They just end up closing the both eyes. Remember, alternate cover test is done when there is a phoria, when you actually don't look out, when you don't, there is no apparent deviation in your OPD, but the parents say that at some point of time, they may have noticed the child squinting. That's when we break the fusion. We need to bring out the strabismus and we do the alternate cover test. But when there is actual tropia which is present, we do the cover test. So what is the cover test? So in the cover test, we cover the apparently fixing eye and we look for the movement in the deviating eye. If the eye moves in, it is exotropia. If the eye moves out, it's ESO, and so on. The next step is the uncover test. So what did we see when we did the uncover test is we look what happens to the eye under cover. Does it still maintain the fixation after removing the cover? Or if it maintains the fixation, does the fixation break with the blink, or it remains with the state of the blink, or does immediately the other eye, the deviating eye, comes back to take up the fixation? So based on these, we actually find out what is the dominant eye, and the notation of alternate exotropia or the dominant and the fixating eye can be made out based on this. So once you find out what is the type? So now by doing cover test, we found out there is an exotropia. So next comes the fact that we need to measure the deviation. For this, we do the prism cover test. So here we usually place the prism with the apex towards the side of the deviation, but notation will always be with respect to that of the base, and we perform alternate cover test here. It's important to perform alternate cover test because we have to bring out the whole amount of the deviation outside, dissociate the eye fully, break the fusion fully, because we need to cover the total, we need to correct the total amount of the deviation which comes out here, which is being measured by doing the alternate cover test, the prism cover test. So for doing any cover test, the most important point is to have a central fixation, to have a good vision better than that of nearly 636 or 624, and the movements has to be normal. But what if the patient has a very poor vision, maybe post-retinal detachment surgery, maybe post-aniridic patient, post-traumatic patient? In those people, how do we measure the deviation? Is by using a procedure known as modified Krimsky test, where we directly place the prism with the apex towards the side of the deviation in front of the fixating eye, and we actually look at what point the deviating eye approximately comes up to take up the fixation. So these are few ways in which we measure the amount of deviation. So once we measure the deviation, next is to check the extraocular movements, ocular movements in all the 9 cardinal positions of the gaze. Look out for any gaze incompetence, look for any abnormal SO or IO actions, look for any pattern deviations, look for any restricted or the paresis of the muscle, especially abduction or the adductions. So based on the abnormal, whatever ocular movements we get, we can do some special tests. Like for example, if you notice a case of superior oblique palsy, you can do Park-Bilshowski's test, or you can do a double Maddox rod test to assess the torsion. If you see a case of 6-nerve palsy or a restrictive case of the strabismus, to differentiate between the restriction and the paresis, we may go ahead with the active force generation test or the passive force duction test in these conditions. And if the patient complains of diplopia, we may go ahead with the diplopia charting by using the red-green glasses and a single streak of the light and assess the actual muscle which has been palsied and the type of the diplopia. Final thing, Never forget the fundus. It gives us a lot of information in case of the strabismus. Look out for papilledema in case of sixth nerve palsy. Do look out for torsion, especially in case of bilateral SO palsies. When it is masked, it's the torsion which gives us a lot of information by assessing the fundus. Look out in case of sensory exotropia. Find out what is the cause of the sensory exo or the esotropias. The last slide, management. Management is a talk by itself after assessing, but still I would like to cover in just the last 30 seconds. There are 3 ways in which we can manage any case of strabismus. Non-surgically, in case of esotropia, hypermetropic glasses, exotropia, myopic glasses, prisms in case of small angle deviations, and in case of paresis. Botulinum toxins in case of paretic muscles, and amblyopia management by doing patching is the most important steps of non-surgical way. Vision exercises, stimulation therapy exercises by either using software or by using orthoptic exercises, especially in cases of intermittent exotropias. Surgically, weakening procedures like recessions, tightening procedures like resection, strengthening procedures like transpositions. Well, this is just an overview of the management which I have mentioned. Strabismus in by itself is a huge ocean, and each one of these can be a half an hour to 1 hour talk. So with this, I would like to conclude that strabismus evaluation and management is like blind person looking at the elephant. So if you just touch one part of the elephant, you cannot find out the make it out as an elephant. Similarly, just don't do vision evaluation. The moment patient comes to you, just don't jump into doing an alternate cover test. Methodical way, going in the stepwise way and covering all the aspects of the strabismus gives an actual satisfaction when the patient comes back to you post-surgically or post in any types of the management perfectly ortho and happy. Thank you.
Thank you, Dr. Deepti, for excellent talk and covering the wide topic in a limited time. Dr. Amila sir, you want to ask any question or any comment?
No, just comment. I think that is an excellent presentation, Dr. Joshi. I think it's very easy to speak. It's easier to speak on complex strabismus, but whenever I hear talk about the very basics of strabismus and what you spoke, it's very difficult to complete that talk in such a short time. Very well done. Excellent.
Dr. Rohit.
Thank you, sir.
Absolutely. I think excellent presentation, Dr. Deepti. And as she rightly mentioned, unless you do strabismus, at least, is definitely one thing which we only improve as we practice. So there are hardly any, textbooks that you can read, except of course, Dr. Pradeep Sharma's. Which we always read and we learn more. But other than that, I think that is excellent. Dr. Subhash, can we maybe do a few talks before we do some discussion? Because I think we are running a little late.
Many time coffee. Dr. Pandey sir, one comment. Sir, you are muted.
Pandey is mute. Unmute, Dr. Pandey. His voice is not clear. I think Dr. Deepti has given the basic fundamentals of squint examination and how to approach a squint patient, because this we used to learn and see the lectures of Dr. Pradeep Sharma and Professor Prem Prakash during our PG time. And you made this so simple and so understandable, like really telling, because the first time I could understand very well, like how to proceed for the squint examination and do the needful for that particular patient. Beautiful presentation, Dr. Deepti.
Thank you, sir. Thanks a lot, sir.
Yeah, Dr. Deepti, this talk was kept on our request.
So it was a request of our treasurer, Dr. Alkesh, to keep one talk on basics.
So that everybody understand and about the squint, so they can do the job. It was an excellent presentation.
Thank you, sir.
This was important for those people, those who are not actually into the squint strabismus and not the squint specialists like us, cataract surgeon, Dr. Alkesh is a retina surgeon, Dr. Bhalla is a glaucoma surgeon. So for us, this talk was really beautiful.
Thank you, sir.
Pandey sir, one comment, short comment.
It was a very excellent talk, and I think she covered most of the aspects. Anyway, as Dr. Rajat Prasad is saying, strabismus is a very complex specialty involving neuro-ophthalmology and motility and a lot of things. So it does take a lot of effort and time to understand the nuances of the whole thing. So she has done a very good presentation, and I think it's really helpful.
Sir.
Dr. Sharma sir.
I think it's a wonderful talk, and for a basic thing, she has covered all the aspects that are required for a beginner. So it's wonderful.
Thank you, sir.
Thank you, Dr. Deepti. We can move to the next speaker. So our next speaker is Dr. Amila. He is consultant eye surgeon and from Child Eye Clinic, Colombo. After having obtained his pediatric ophthalmology fellowship in Secured Hospital, Canada in 2010, he has been practicing as pediatric ophthalmologist in Colombo. His area of focus has been strabismus and pediatric cataract surgery. So he will be speaking when neuroimaging is indicated in strabismus. Dr. Amila, over to you.
Right. Thank you very much. I hope my slides are visible and I'm audible.
Yeah.
Yeah, you are audible and slides are visible.
Thank you. So thank you very much, Professor Dadia, for inviting me to be once again part of this group of esteemed strabismus surgeons from India, and also Professor Sehan from Turkey. So now I think Dr. Joshi's presentation built up well to my presentation. And while everyone else in this seminar will be talking about how to fix complex strabismus, I'm going to be talking about something slightly different, maybe something more relevant to the general ophthalmologist or the trainee, is that, when a patient comes to us with strabismus, we've got to first make sure that this is only a strabismus, and then we can figure out how to straighten the eyes. We've got to make sure that there's nothing sinister going on behind it. And that's what I'm going to speak about. Now, a lot of our decision-making in when to neuroimage, I feel has its roots from maybe a few decades ago, when neuroimaging wasn't as relevant or wasn't as available to us. So, but what we found out is, even though neuroimaging has become more available and easily accessible, still some of those same concepts have carried on. So we'll touch a little bit on the different situations in which somewhat routine strabismus patient should be imaged. So the clues in history. So I would say, some of these are very obvious. A loss of vision, a loss of visual field indicates imaging should be done. Headache, weakness, numbness of face or extremities. If there's any history of trauma, especially to the head or the orbit, surgical history, and we can't forget about giant cell arteritis. So we've got to look for clues and make that part of our routine to look for, is it only strabismus or is there anything else involved? While examining the patient, of course, like Dr. Joshi mentioned, we do the basic examination, vision. Of course, the pupil examination is something that we always have to make part of something that happens regularly, not only when we see a cranial nerve palsy. Visual fields, I'll speak to you why that's important. Nystagmus, proptosis or the orbital signs are important, as obviously would be optic nerve signs like papilledema, optic atrophy. So these clues in examination also will tell you that you're dealing with something more sinister than just plain strabismus. So if you've got an esotropia, I would think of neuroimaging, of course, when I do see an element of an abduction deficit, facial nerve palsy, optic neuropathy. Now, in Sri Lanka, there is a very controversial area, this acute acquired commitant esotropia, which is not a very common strab condition, but we know the literature tells us that, and in my experience as well, the majority of these are due to breakdown, infusion, stress, myopia, extensive near work, which all kids are involved in. So I won't necessarily go and image any of these patients, especially in younger children with this sort of condition. But of course, the older the child gets, and if this is associated with nystagmus, headaches, or cerebral signs, then I would feel more inclined to image Otherwise, we'll be imaging, imaging kids for something that happens pretty much less than 5% of all causes will be something in the, and we see this more in the older patients. When we come to an exotropia, we've got to remember that a very mild third nerve palsy in a child can also present with these intermittent fusions simulating an intermittent exotropia. Just keep that in mind. And also intermittent exotropia, or it could be when a constant extinct, could be an attempt by this child to increase their visual fields if they've got a homonymous visual field defect. So I routinely would check every child, just a confrontational visual field assessment when they present to me with an exotropia, intermittent or constant. Also, where I'll be a bit more concerned is if we get children who present to us with intermittent exotropias, generally more for distance, but then when they have a near more than distance or there's a convergence insufficiency, we've got to just keep in our minds that possible neurological disorders like past head trauma, dyslexia, Parkinson's disease, subdural hematomas and strokes. So again, considering neuroimaging in these kids might be an option as well. Now, once we come to cranial neuropathies causing strabismus, we've got this very fixed thing, and we're all aware of this. It's a very good guideline that really hasn't changed with much with time. Any patient younger than 5 years of age, any history of any type of cancer, there are multiple cranial neuropathies, additional neurological dysfunctions, incomplete or pupil involving cranial third nerve palsies, and isolated mononeuropathies that progress. We keep following up and they progress or they don't resolve in 3 months. The general advice is to image these patients, but specifically just a few points on each of these areas. When we talk about the third nerve, we know the pupil involvement now, and you've got to keep looking for this pupil. Does it get involved at a later visit as well? Is there aberrant regeneration? And like the previous slide said, all children and those below the age of 50 years with no alternative risk factors should be imaged as well. And you've got to keep in mind that aneurysms are likely to affect the pupil motor fibers incomplete, but sometimes spares the pupil motor fibers in the superior division palsies. And also on the other side of it, remember that 20% of patients with microvascular third nerve palsies may have a pupillary involvement as well. There has been, even in Sri Lanka, I mean, there is enough controversy where we've got some doctors imaging all patients with third nerve palsies, right? So they pupillary get involvement with or without diagnosis, and they get an MRA to evaluate for an aneurysm. But I feel that's a little bit of an overkill, but there has been lots of literature to support this approach as well. Fourth nerve palsies, of course, when we see a congenital, typically an isolated fourth nerve palsy with a large vertical fusional amplitude, inferior oblique overaction, and facial asymmetry doesn't really warrant imaging, even if it's noted later in life. But remember, in acquired causes, 1/3 are caused by trauma, 1/3 roughly by vascular causes, and the remaining idiopathic. Again, in fourth nerve palsies, like in the acute committant esotropias, less than 5% of these fourth nerves are caused by a space-occupying lesion. If you see a bilateral fourth nerve palsy, is definitely and associated with other findings, that's definitely an indication acquired bilateral to image. Going on to the sixth nerve palsies, and remember that these are the most common ocular motor paralysis causes in adults and the second most in children. Again, non-microvascular cause of sixth nerve palsies may include demyelinating diseases, metastasis, aneurysms, intracranial hypertension, all indications why we should be imaging these patients if those initial criteria are not fulfilled. And you've got to remember that in an infant, especially, a very mild adduction lag may be a difficult thing to see on simple adduction testing. So you may need to use O'Kane drum or doll's eye testing to uncover this lag. Now, nystagmus, I've just included that because it is a motor disorder. So if you've got children, got a child with poor vision, this could be from the retinal pathology. And if the OCT and we would want OCT and ERG findings are non-conclusive, then again, imaging, neuroimage, if there's optic neuropathy, decreased visual acuity, cannot be explained by the examination, or the ERG or the OCT results, again, we are pointing towards imaging. So these are the areas where you get either seesaw nystagmus, spasmus nutans, downbeat nystagmus, periodic alternate nystagmus, convergence retraction nystagmus are all causes of why we might definitely want to image this patient rather than not. And then last of all, we come on to acquired strabismus, mainly due to trauma. This is something that if we are suspecting an orbital fracture, hemorrhage, or entrapment, and because of their orbital bone composition, they are at particular risk for muscle entrapments with inferior orbital wall fractures. These are reasons to image these children as well, because they present with strabismus sometimes. The take-home message is, we've got to be, while managing all the complex strap, we've got to be, as a general ophthalmologist and as a more specialized strabismus surgeon, we all be aware always of the possible sinister causes of strabismus. Be scientific in our approach to ordering imaging. We should be able to give more reasons than just the patient safety, which is also important. We've got to be more scientific with our literature approach to why we are ordering the imaging. We've got to consider patient safety and available resources. And I know, a lot of what we see, the guidelines, they come from a more developed centers. But in Sri Lanka, I know India has got some really good centers as well. But in Sri Lanka, what happens is we've got to be mindful of the available resources and the patient's affordability in ordering imaging for all these cases. Have a very good rapport with the patient's family, because even if you are delaying imaging, the patient's family, they've got to, I generally would spend a bit of extra time explaining as to what the possibilities are, what the percentages are, and the reason why we might delay the neuroimaging rather than do it right away. And of course, you've got to have a good rapport with your neurologist and your radiologist when you're dealing with these things. I make sure to have a drink with my radiologist and my neurologist on a regular basis, so that I can call them up and tell them that I want this done urgently. Otherwise, they'll always find a reason to delay it. I'm very interested in finding out, because from the other speakers here in India, especially, as to what you all would agree or disagree with the approaches I put down here. Thank you very much.
Thank you, Dr. Mila sir, for excellent talk. Dr. Rohit, any comments?
Excellent presentation, Dr. Amila. I think you really highlighted the key issues and the importance in discerning when to image in resource-constrained countries like ours. Of course, the key, again, as you pointed out in the end, was to have a very good rapport with the patients or parents, because you want them to follow up and you want to observe improvement. We have burnt fingers in patients whom we did not image initially, but within a short while they came with progression. So a 6th nerve palsy progressed to a gaze palsy or associated neurological symptoms. So the key message would always be that if you are imaging, then always make sure that the patient can follow up with you or somewhere and report if it worsens. And of course, it's just not imaging or not imaging. You must have an etiology behind the cause for the strabismus. So, in young patients who, and now in India, and I'm sure in many parts of the world, young patients also have significant systemic disorders. So identify the systemic disorder, make the patient aware that these are the possible causes, and their management is very, very important. Again, and always be aware of red flags, because sometimes anything can coexist with diabetes, considering the prevalence of diabetes and hypertension in our population. But very nicely covered, Dr. Amila.
Thank you.
Dr. Pandey, sir.
I can just say very nice presentation by Dr. Amila. I just want to say one thing, that if you suspecting something like skewed deviation, or even in acute acquired competent esotropia, where if there is something which is pointing out that this could be a non-isolated situation, some nystagmus or something, we always need to look at it if there is a papilledema. So some of these cases present as initial as say AACE, or a skew which may look like 4th nerve palsy, and we don't suspect that aspect. Or in cases of cerebral palsy, we have large number of periventricular leukomalacia, HIE, and cerebral palsy. They have quite often have strabismus. So these need to be evaluated, I think, with neuroimaging along. And about these nerve palsies, I think there's a lot of controversy. Some say you all should be imaged. Some say in Western side, if you go to America, they would image them all. But with us, we would like to wait 3 months and see how it is behaving, and then accordingly take a decision.
Dr. Deepti, you want to say something?
It was an excellent talk, but I would like to ask all the experts here that with the current situation when that acute comitant esotropias are on rise, it really becomes dicey when real parents come and suddenly they say since 3-4 days it is. So what is the opinion about everybody here about the imaging in those situations, considering every OPD we are having nearly 2-3 kids with acute comitant ET nowadays, sudden onsets?
So may I comment on this?
Yes,
Yeah.
Dr.
Yes.
Sian, please.
Yeah, well, as we all know, this with the high use of digital devices, the acute comitant esotropia has become an issue that it became an everyday issue. But the confusion is now, many ophthalmologists, at least in my country, regard any acquired esotropia as acute comitant esotropia, but this is not the case because we know acquired esotropia is very common and it starts later in life and so on. So if in case of in the absence of any additional signs that, like fundus or any neurological signs and so on, for any child, let's say a 3-year-old boy came with a sudden squint but has nothing else neurologically, I don't see any reason to image this child because this is also an invasive procedure to image these children. They require anesthesia or sedation and so on. So this is the main problem in my country is now that. So I see so many straightforward acquired esotropia cases that when the patient came to me that they already had an MRI that someone else has ordered them. So I think the ones who require MRI are the ones who had late onset. So the usual straightforward acquired esotropia, there's no reason to scan them. On the other hand, for the acute onset esotropia, well, we image them obviously, but I must say that in my clinical practice, I see so many acute comitant esotropia, especially in recent years, I think as many like you, and I haven't seen any case who had a neurological problem behind. But the ones what they have behind is actually they mostly are the monofixators before. So when those who recover, you can see that they were monofixators. Anyway, so I think there is too much MRI asking problem, at least in my country, and so we need to make the distinction well for our young colleagues. What is acquired esotropia doesn't mean acute comitant esotropia, the late onset acute comitant esotropia. Just as a small additional comment, for the classical approach of not asking MRI for the ones over 50s and to wait for some time and so on. And there's so much literature information in recent years, as you know, that this concept should be changed, and we should also ask for imaging as imaging methods has become more available for, so we need to ask for imaging for the ones over 50s as well, if the patient do not have a, let's say, relapsing paralytic problems with diabetes and so on. And so there is some evidence, as you know, which supports the change of this policy. What do you think on that?
Dr. Sharma, sir?
Yeah, I mean, there are some quite large numbered reports indicating that we should change our policy not to ask for imaging for those who are over 50 years old. You know, the classical approach is to wait at least for 1 month before asking any imaging and to see whether it is decreasing or not. But on the other hand, we know that the microvascular paralytic problems may even increase in the first month. So the distinction is very gray, I must say.
I think in India,
So in my practice, I've changed my approach to ask for imaging for the ones who are over 50s if they don't have a very apparent cause.
So I think we will have to go by the fact that if we can find out the etiology, like if it's a deranged diabetes, hypertension, which can explain in cases in which there is a pupillary sparing third nerve palsies, we usually tend to not do an imaging. But those cases which have a pupillary involvement, of course, irrespective of the age, we will have to do an imaging to find out the cause. Even if there is a pupil sparing, it's better to follow up for 5 days or 1 week. Don't delay it too much. In that period, if the pupil gets involved, again, it becomes an indication to image. So that would be our thing, that we will be imaging in order to find out the underlying neurological problems. So that was one aspect of the imaging, which Dr. Amila very nicely covered. The second part, I would say, is that we do imaging in situations where, apart from the cause, we will also be like to know what is the therapeutic approach that we may be doing. For example, in myopic cases, as I might be covering later on also, we may do imaging to know the displacement of the pulleys which are there and which changes the approach of surgery itself. These surgeries, again, you may do an imaging when you want to find, if you don't have the detailed records and you want to know what was done prior, then we do imaging. And nowadays we have the possibility of ASOCT or UBM, which may also be done to help us in deciding what was done earlier. Then there will be a third situation in which we do imaging for a more academic reason, maybe like congenital cranial disinnervation disorders, like the Duane's, like Mobius syndromes, in which, again, if we do high definition MRIs, we can find out what is underlying pathologies in these cases. And that again helps us know what is the basic underlying pathology. So availability of the imaging being there, you can have more of imaging done. As I think Dr. Deemer once said, that now we do not ask so much when we have a sixth nerve or third nerve palsy when we image. But in cases of committant strabismus, also there may be situations in which we may be doing imaging if we have some unresolved queries. For example, if you have a displaced pulleys, it may explain why there is a V pattern in spite of the fact that there is no inferior oblique overaction. So there are situations in which you may do, even in those so-called non-neurologic strabismus, the committant strabismus. And of course, as was talked about, esotropias, acute committant esotropias, if they cannot be explained by accommodative cause, just by the fact that they had a prolonged digital work, near work, then again, imaging, we have found some children having a problem in the upper brainstem, which can be probably taken care of. So I think it requires the clinician's approach in order to see when to image. It's not just a simple answer, but there are several things which we'll have to use as red flags that will help us in guiding when to do and when not to do.
I think in Indian circumstances, Dr. Subhash.
Yes, sir. Yes, sir.
I was saying in our circumstances, if we image 100 ischemic palsies, the incidence of some SOL or something else is about 2%, I think, in Western studies also. And
I think we are
is very much loaded.
We are over investigating.
And we are overloaded. We are the largest population globally now. So our radiology systems are already loaded. So I think we should wait and watch for about 3 months. And after that, if they are not resolving, then of course they should be imaged. And in the case of sixth nerve, if you have a papilledema or something or a nystagmus, then they must be imaged immediately. Or a bilateral fourth nerve also needs to be imaged. So I think with certain conditions, we should keep that in mind and accordingly decide.
And especially these days, patients are quite aggressive also. And many times what I have seen in my practice, like patient himself ask you to image. And many of them, they get imaging done themselves and then come to you. So in that situation also, I think they are so aggressive. They read and they say like, you have a third nerve palsy, and they go home and read in the Google and everything, and they go to the imaging center and get it imaged, and then they put the reports
They
to
feel
you.
very happy that there is nothing, no SOL. So that's one thing, it gives a feel good factor, but money has gone without any positive outcome at the same time.
Absolutely.
So it's a
But the
catch-22
key
situation.
importance also is the appropriate imaging.
Yeah.
Judicious.
Judicious.
And
I think
the
judicious is the
correct,
word.
because CTs don't help us. Even in a third nerve, if you in a third nerve, you're suspecting an aneurysm. So all aneurysms may be missed by screening MRI brains. For that, you need an MRA actually to be definitely. So
I think
that lulls you in a sense of complacency. And that's also like important. So you need to be aware of that incorrect or inappropriate or inadequate imaging can be, dangerous also. Little knowledge.
Misleading, very misleading.
So you should be judicious in order to avoid judicial problems.
Yeah.
But we don't know when it is judicial and when
So
it
you
is
have to be,
judicial.
always seeing and don't miss any
Red
red flag.
flag signs, sir. Red flag signs.
Red
Yeah, but I think like what everyone has said, it's really key. Number one, the imaging, in my opinion, has gone up. Number one, because it's more available. Number two, because patient information is, like Dr. Prasad said, you just Google this and you come up with all the worst case scenarios. I mean, I have lots of pediatric kids coming to me with headaches with the MRI in their hand, just headache, MRI done. And then they come to you for everything else, And the second, the next thing is, like you said, the legal cases. So I think this is where I think even Dr. Rohit mentioned where the proper rapport and also the documentation of your discussion with the patients are so key, that you're explaining to them, this is what you're doing, this is the percent. I mean, so I would spend a bit extra time and save them that when they understand, they become less aggressive and they know that you're being safe and you're not sort of just unnecessarily just throwing out neuroimaging at the drop of a hat.
Thank you, Dr. Amila sir, for excellent talk. Dr. Rohit, kindly invite Dr. Pandey and introduce him.
Sure, thank you. So an absolute pleasure to invite Professor Pandey, who is from my alma mater, did his MBBS and MD ophthalmology from, and subsequently he joined LHMC as professor and then moved over to hospital, from where he retired as a director professor just a while ago. He has extensive clinical teaching and research experience in strabismology and neuro-ophthalmology, and has more than 50 indexed publications with presentations in many national and international conferences, where he's chaired many sessions and delivered some excellent talks. He has won the AISD Athalwe Award and delivered the PK Jain oration in the DOS, and he has been the editor to the Strabismus and Pediatric Ophthalmology Society of India, and is currently the secretary of the society. So pleasure to welcome Dr. Pandey for his talk. He'll be talking on superior diagnosis and management of superior oblique palsy.
Thank you, Dr. Rohit, for your kind words. And I would like to thank, am I audible?
Yeah,
Yes, sir, audible.
I would like to thank Dr. Subhash, Dr. Rajendra Prasad, Dr. Bhalla, and everyone for this invitation. I will be talking on superior oblique palsies, which has been partly covered. Share screen. Now, just a moment. Am I audible?
yeah.
Yes, Dr. Pandey.
Yeah, I can only see my slides. I can't see the rest of it. So I'll be talking about the superior oblique palsies.
Dr. Pandey, your slides are not visible.
It's not open yet.
I made it full screen.
Could you slide share first before you make it full screen? Could you please share your slides?
Here's the screen.
Now, how do I
That'll
go
be at the
back?
bottom of the Zoom portal.
The green button.
So you'll have this bar coming up, which will have this green button called screen share.
No, it was there. I did that, and then I shared the screen. And then
Just unshare and reshare. Sometimes it takes a while to do that.
where is unshare?
So if you are shared, it will be showing.
Yeah.
You
It
know,
will be red
unshare.
there.
I think I will have to go down the whole thing, then it will show. Let me see once.
Yeah, go away from full screen. You'll have to.
Now I'm to the last slide. Now what you were saying?
In the Zoom portal, you will have this. If you are in your screen, you're showing screen share, then you'll have to unshare first. On the top, you'll have this button coming up, stop screen share.
Where is the, if I press Zoom, then I see you. Shall I click on it? Zoom.
Yes,
Zoom is only on.
you'll get a chance to go back to the Zoom.
Yeah. Now it's saying share. Shall I share now?
Yes,
please
now
share.
share your screen. Yes, yes,
Good.
now your screen is shared.
Yeah.
Great. Now do
Thank
full
you.
screen.
Thank you so much. This is software I always find a bit. But now it's stuck on the last slide.
Yeah,
Go
so
to
you
the
just
first
go
slide.
back, select your first slide. You can rotate your slides, there's no problem. Yeah, just go back up. Yes. Keep going up.
Wow.
Yeah, yes. Very good.
That's good. So you're talking about superior oblique palsy. I think we already have had a very nice
Sir,
discussion
full
regarding
screen, full screen, full screen.
now full screen.
Yes,
I hope nothing goes wrong again. Then
let's
No,
hope so.
Just click at full screen.
The bottom one, you can see that full screen sign.
No, yeah.
This one.
Yes, this is fine. I click this. Yes.
Great.
it's okay.
Yes,
Good.
sir. Please go ahead.
Thank you. Thank you so much. So the superior oblique palsy, as we know, these are known since mid-19th century. The common forms of paralytic and vertical strabismus. The first surgery was done by Edward Jackson. As I said, that was of SR recession and temporal transposition for extortion. That was 1903. Superior oblique palsies are diverse in presentation, frequently pose diagnostic and therapeutic challenges. Now, a bit about anatomy, because superior oblique is the only nerve. This is the thinnest nerve, and this is the only nerve which exists dorsally from the midbrain, crosses in the anteromedullary velum, goes around the midbrain, and comes anteriorly. So that way, this has the longest course, and being smallest nerve, it is prone for congenital superior oblique palsy, as we know, and CCDD is also. Only thing is that there's little scope for disinnervation. So it's only primary disinnervation with little scope for secondary disinnervation. And about acquired palsies, as it is crossing in the anteromedullary velum, it is crossing, and if there is a shearing force, this can get damaged there, and you have a bilateral superior oblique palsy. After that, it is going to run under the tentorium cerebelli, and if there is countercorp injury, this can also give rise to superior oblique palsy. So for superior oblique palsy, we may not have very severe head injury. It may happen with minor trauma also once in a while if there is a lot of shearing force. Now, a little bit about these vestibular pathways, because we do this thing, head tilt test, and we can also have a ocular tilt reaction, which may look like a superior oblique palsy. So we need to distinguish these conditions. So we should know that there is these vestibular pathways are coming in the pons, crossing at the level of the sixth nerve nucleus and ascending up in the MLF till the RIMLF. So anything along this also can create issues. This is showing the fellow travelers with the superior oblique fourth nerve. So if there is a non-isolated one, these structures can also be affected, and you may have things like INO. Those things can be there. Now there is a compartmentalization of innervation with the our extraocular muscles, more so with superior oblique also, that the medial part and lateral part, it just divides into two parts before entering the muscle. So the medial part is going to supply, which is going to have torsional effect, and the lateral compartment is going to supply, which is going to have depression effect more. So you may have a palsy which may have more of torsional issues or more of depression issues. So the presentation can be quite varied in some of these cases. Now, clinically, as we know, it is a very diverse presentation, as has been talked. You can have a congenital one or an acquired. It could be unilateral or bilateral. Bilateral can again be masked, which looks like unilateral palsy, and a lot of effort has to be put in to distinguish that is it actually bilateral or unilateral. This could be isolated or non-isolated. If it is non-isolated, we need to look at differently. Maybe we need to neuroimage them immediately as compared to isolated, where it may not be always very urgent. Then there will be muscle sequelae like inferior oblique overaction, superior oblique underaction, and inferior rectus contralateral overaction and inhibition palsy of the contralateral superior rectus. But these sequelae may come, may not come. The commonest thing to happen is that you have inferior oblique overaction and V pattern. So the superior oblique underaction may not be there in a good number of cases. In fact, in majority of cases, the superior oblique underaction may not be there. Only about 30% of cases are known to show superior oblique underaction. So later on, there is a spread of comitance in old cases. So these three-step tests may be a bit mixed up. So it may not be incomitant deviation. There could be absent tendon or SR contracture, which has been already discussed by Dr. Sahan very well. That these cases are again very different because the presentation is going to be different. There could be issues with the fixing eye, which eye patient is fixing. There could be an esotropia along with it or exotropia. More often I have seen they go for exotropia if they are bilateral. And there could be amblyopia also, but that's not very common because they do manage some kind of fusional mechanism. Now, is congenital superior oblique palsy a CCDD? There have been a lot of evidence from MRI that there is absence of hypoplastic fourth nerve on MRI in up to 72% of cases of congenital fourth nerve palsy. There is an overlap with Brown's. There are cases I'll be showing one that superior oblique palsy in one eye and in the same patient Brown syndrome in the other eye. 30 to 50% of reduced volume has been shown of SO on MRI and SOP. That applies to both congenital as well as acquired cases. And there is correlation of hypoplastic SO with hypoplastic nerve. So there is a strong association that these are actually congenital ones are CCDDs, but there is no degeneration because there is nothing close by to degenerate. So this is a primary degeneration, but without any secondary degeneration. Now, clinical presentation can be varied. Like in congenital cases, they may be asymptomatic. They may even not be a primary deviation in primary position if they are having an AHP, or it may only be in down gaze or up gaze. It happens at times depending upon the presentation. AHP is quite common and quite often it is there, but it's not that it is a must in all the cases. Usually it is a head tilt, but you may have a good number of cases, about 20 to 30%, where there may be no typical head tilt. They could also manage with face turn. That means putting the eye in abduction so that the vertical is less. Or if it's a bilateral palsy, they will have a chin down position because that's the direction of the movement of the superior oblique. PPST may not be there. There could be asthenopia and cervical discomfort because of AHP and asthenopia if they are trying to fuse these images. XTET and amblyopia, I said these could be there. V pattern is important to keep in mind. And objective extorsion. In acquired cases, it is more of diplopia, which is very troublesome in down gaze, particularly as they are climbing stairs or reading. So acquired and congenital ones are quite different in many ways because they have very different presentation. This is showing a consistent AHP, as you can see, from a very small child to a grown-up person, a very typical AHP to the opposite side. He has a right side superior oblique palsy and is having very consistent AHP to the left side. This is just showing the guidance exercise traction test for the obliques. This is important to do in congenital cases, not in acquired, because acquired ones have normal tendons. They are going to have normal laxity. But in congenital cases, you need to do it because that will show you that how lax tendon is. And we always compare with the other eye because it's very subjective. You need a lot of experience and need to compare with the other eye to know what actually is the situation. Hawk's step, we have said that it is very important for superior oblique palsy, as we all know, but it has its vagrancies because we don't take oblique gazes, and there could be situations where it could be mimicked, like in IR contracture in the other eye, there could be skew deviation, there could be a dissociated vertical deviation, there could be pulley heterotopy and associated horizontal deviations. All these things can mask and create problems with the three-step test and sort of congeal it. Fundus torsion is another very important and essential aspect whenever we are evaluating a superior oblique palsy. The congenital ones will not have subjective torsion. They will only have objective torsion on fundus photography, which you can see. But the acquired ones will have subjective torsion, which can be very troublesome. And this we classically measure with double Maddox rod. We put both red Maddox rods, not one white and one red, that can be dissociating, and make the room dark and see how much is the torsion. This is important to see in both the eyes and accordingly we need to plan the surgery. This is, you can see there is an extorsion in the right eye, and normal left eye is having normal torsion. This fovea relationship should be the lower 1/3 of the fovea should lie within lower 1/3 of the disc. So as you can see, the right side this is showing extorsion. This is a classical patient with inferior oblique overaction, class 1 SOP. Superior oblique underaction is not very marked. There is a V pattern. Some of these, in fact, can also have a exo in up gaze and ESO in down gaze if they are bilateral. So if you find an exo in up gaze and ESO in down gaze, you should think of a bilateral palsy. This is again showing the same, that there is an extorsion in that affected eye. This is showing an traumatic acquired unilateral left superior oblique palsy. You can see the AHP is to the right side. And here you can see the motility. There is inferior oblique overaction, and there is superior oblique underaction, on the left side, and there's slight VXO in up gaze. And he was quite troubled by diplopia. We did Haradaito on his left eye and did IR recession. So with that, he was on the other eye. So he was okay with that. This is showing on tilt. You can see it is coming on the left tilt because it is left superior oblique. This is showing extorsion in same patient in the left eye. These are again acquired bilateral symmetrical superior oblique palsy. These are also quite challenging because you may think that there is nothing and patient is having a lot of complaints. So you may even sort of think that he's just being functional. But you will find that there is some extortion, some exo in up gaze and some ESO in down gaze. And some of these may look like an ESO deviation. You find there is no lateral rectus movement is full. And why there is ESO? So it may look like acute acquired competent esotropia. And if you, once you look at, you do their head tilt test, it may come positive on one side, it may not usually come positive on both the sides, like what is happening in masking. And when you look at the torsion, you find the real picture. So torsion evaluation is very important in these cases. Now you can see in this upper slides, you find extortion in both the eyes, same patient. And after Haradaito on both the eyes, this says the condition has improved. So very important to look at torsion. If it is more than 10 degrees, you need to do a Haradaito operation. Now there will be certain uncommon presentations I'd like to share in this meeting. One is there is a SOP with congenital Browns. There is masked bilateral. There is absent SO tendon, or if there is SR contracture, pseudo overaction of the SO. This has been already been discussed. Or there is fallen eye syndrome, or non-isolated or occlusive reaction. Now you can see here that this is a child who also had albinism. He has superior oblique palsy on the left side and the Browns on the right side. You find a large exo in up gaze because the superior oblique palsy and Browns both are going to add to the V pattern exo. So you have a large exo, and in down gaze he is okay. But if you look in the sides, the right eye is not depressing, not elevating, and left eye is elevating in adduction. So it's a very typical picture, but if you're not aware, you will miss it. This proves that these cases are CCDDs because same disinnervation on one side has given rise to lax tendon and superior oblique palsy. On the other side, it has given rise to a tight tendon and a Brown syndrome. So now you will have extorsion in your left eye and in torsion because of Browns in the right eye. So you can here have something like what is known as conjugate torsion in these cases. This is showing head tilt, which is positive on the left side because there he has a superior oblique. This is showing the tendons in the superior oblique palsy, and if you see in the Browns, it is very tight and fibrous kind of short tendon. And on ABT, you can always distinguish these two. This is showing a bilateral congenital masked SOP. Mask means that this was looking like left, and you can see the right looks like a fallen eye. And we thought it is on unilateral 6-nerve palsy, superior oblique. There's a large V, and in down gaze, he's not going into ESO, but some of these can also go in ESO. Now, what you should think of is on tilts, they don't come always, they will come only on one tilt. You should do 9 gazes, and if you find some hypertrophy, alternating hypertrophy, it may be good, but you may not even find that alternating hypertrophy in these cases. So they can really be challenging in those situations. In those cases, you need to look at V pattern torsion, and if there is small primary position hypertrophy, because if it's bilateral, usually the primary is small, but here you find a large one. And now if you look at the torsion in this patient, this is on tilt, which is coming on the left side because that is asymmetrical. And you find extorsion in both the eyes. So that shows that this is a bilateral situation, not a unilateral palsy. So if you do fundus torsion, it is quite helpful in some of these cases. This is showing a right ocular tilt reaction with left INO and LST. You can see that the left eye is not adducting. There is an exotropia, and up gaze there is V pattern. And if when you do his fundus, they also may come on the head tilt. They might simulate superior oblique palsy. Now these have a conjugate torsion, means the eye which is hypertropic has intorsion and eye which is hypotropic has extorsion. Whereas in superior oblique palsy, the eye which is hypertropic has extorsion. So this way you can distinguish these cases. Quite not all the cases, you may not have very typical presentation in all the cases, but if you find a conjugate torsion, it is always supporting a diagnosis of a ocular tilt reaction very strongly. So always look for torsion in these cases. This is another one. This is left ocular tilt reaction. There is bilateral superior oblique palsy because of pilocytic astrocytoma in the cerebellum and cerebropontine angle. You can see a large exo in up gaze and large ESO in down gaze, and there is also ESO in primary position. Movements are abduction is full both ways, so it looks like as if she has a six-nerve palsy, bilateral or a large ESO, diplopia, but the movements abduction is full. Now, when you look at this, was a large mass pilocytic astrocytoma sitting in the cerebellum and CPA angle. Again, you find here conjugate torsion. The left eye is extorted and the right eye is intorted. So this kind of torsional picture is very suggestive of an ocular tilt reaction. Now, after 6 months, see what has happened. Both eyes have gone for extorsion. This is because the ocular tilt reaction part has healed, resolved, and now the superior oblique palsy component is left. So both eyes are showing an extorsion in this case now. So that one thing to keep in mind, that these ocular tilt reactions may heal, may recover, and they may not need active intervention in all the cases. Now, the differentials we need to consider in these cases is skew deviation, what we said about ocular tilt reaction, DVD, thyroid eye disease, ocular myasthenia gravis, Pulley abnormalities as we're talking, floor fractures, and contralateral IR contracture, which can quite often simulate a superior oblique palsy in the other eye. Now, surgical treatment, I'll just be talking in very brief manner. If there is a primary position hypertrophy up to 15 prism diopters, then it should be corrected with one muscle by and large. If we can IO if it is overacting, otherwise, if quite often IO is overacting, so that is the target muscle, and it is very forgiving muscle, very accommodative muscle, as we were talking some time back. So whatever you do, it forgives you. If IO is not overacting, then if the SO is lax, then do SO tuck, or if you do or SR recession and contralateral IR recession, depending upon the situation and deviation in different gauges. If the PP hypertropia is more than 15 prism diopters, then two muscles need to be touched, one IO and one other muscle, depending upon the incompetence. If the PP hypertropia is more than 30 PD, then you may need to touch three muscles also in these cases. Now, in bilateral cases, things are a bit different. If the X-angle torsion is 10 degrees or more, we need torsional surgery. This applies to unilateral palsy also. If the torsion is more than 10 degrees, it cannot be corrected by inferior oblique or superior oblique tuck. So these need to be done. Haradaito procedure needs to be done in these cases. If there is X-cycle of less than 10, this can be managed otherwise. If it is less than 10, you can do bilateral IO weakening or SO tuck, depending upon the presentation, or both may need to be operated. Then you can do bilateral IR recession with medial transposition for torsion, or MR recession with inferior transposition can also be done if there is no deviation in primary position. It may present as a unilateral palsy, as we said, if there is masking. So these cases need to be done. And Jampolsky rightly warned that all cases of superior oblique palsy should be treated as bilateral till bilaterality has been excluded or ruled out. So always think of bilaterality, rule it out, and then only treat it as unilateral. Now, to conclude, this commonest cause of vertical deviation, suspect bilateral involvement, especially in traumatic ones, because as I said, they are just below in the antemedullary velum where they can be damaged by shearing force. So both nerves can be damaged asymmetrically. The commonest are congenital and traumatic are the commonest ones. And there is a great diversity in clinical presentation and surgical armamentarium and management. Thank you.
Thank you, Dr. Pandey sir, for excellent talk. Dr. Amila sir, any comments?
Dr. Pandey, you could unshare, please.
No, I think there's a great talk. I mean, the time
Yeah,
is
yeah.
always going to be an issue to discuss this in brief. Like I think Dr. Joshi said earlier, each of these areas, the treatment, the diagnosis, all these areas, just individual talks. But again, it can be quite confusing because the presentations can be very, very mixed. So I think knowing all the rare present or relatively less common presentations help in managing these patients. So very good talk, sir. Very good talk.
Dr. Sharma sir, one comment.
I think we are running out of time. How many speakers are left? Because we
Three.
have only 20 minutes left. And there are 3 speakers, so it went.
Sir,
You may extend that, I think.
we will extend by 15 minutes.
So I think let's cut short the discussion and have the presentations, and then we can discuss.
Yeah.
Because it will go out of control otherwise.
Go.
Can we have the next speaker? Or is it me? I don't know.
Sir, I think it is you.
It's
I think it's you only.
Okay.
no, it's me as per the order.
Rohit, yeah. So, Dr. Balla sir,
Yeah. Can I introduce the next?
yeah, kindly introduce Dr. Rohit.
Yeah. So our next speaker is Saxena, and he's going to talk on diagnosis and management of difficult cases of third nerve palsy. Dr. Rohit Saxena, Professor Rohit Saxena is also Vice President of DOS at the moment. He's done his graduation and post-graduation along with PhD from Dr. RP Center for Ophthalmic Sciences, AIIMS, New Delhi. He has he's principal investigator in 8 projects, and he has many publications, more than 250 index publications. He has been conferred with more than 32 national and international awards. He's editor of 3 books and has authored 32 chapters in the books. He's an invited speaker at more than 300 national conferences. He's also secretary of Indian Neuro-Ophthalmological Society and member secretary of AIIMS Ethics Committee. He has occupied numerous important positions in DOS, secretary 2011 to 13, editor DOS Times in the same period, and editor of Delhi Journal of Ophthalmology. Over to you, Dr. Rohit, for your talk.
Thank you. Thank you very much, Dr. Balla. I'll just start my screen share. I'll essentially be talking on management of third nerve palsy because I can see that we are running a little short of time, which is really the most important thing to worry about. We've discussed imaging in third nerve palsy, so I would not be talking about that. My screen is visible?
Yeah.
Yes, it is visible.
Okay, great, thank you. So I have no control. We know that managing third nerve palsy can be quite a challenge because 4 of these 6 muscles are affected, and we really have very little management options in these cases. But as we are seeing in every aspect of ophthalmology, even in strabismology, particularly third nerve palsy, we are seeing some increasing options to manage. So essentially, all the possible options that we have for third nerve palsy could be summarized in this slide. These are essentially for the horizontal correction or very associated with very mild vertical correction of third nerve palsy. Of course, if it's an individual component third nerve palsy, like involvement of only 1 or 2 muscles of the supplied by the third nerve, the management becomes more tailor-made and should be dependent upon the presentation of the patients. So I'll try and restrict myself to managing complete or near complete third nerve palsy. The options would be maximal or supramaximal recess-resect procedures of the horizontal recti, which could be involving or could be performed on the same eye which has the third nerve palsy or the other eye in order to create a fixation duress. It could be, an option could be a lateral rectus periosteal fixation of the involved eye, essentially eliminating the only rectus muscle that is active on the globe, along with a large medial rectus resection. a globe anchored to the medial orbital wall with a large lateral rectus recession, and the very recently popularized nasal transposition of the split lateral rectus muscle. So I'll try and put into perspective where I personally feel each of these muscle procedures has a role. So a recess resect procedure of the involved or contract lateral eye would be a useful procedure if you have a fair amount of adduction. The medial rectus has some strength left, you'll be able to use that strength with a large supramaximal recess resect procedure. Now, remember, we are repeatedly using the term supramaximal, essentially trying to signify more than what we would normally do for comitant procedures. We have limits of horizontal of any recti procedures for the maximal amount we can do of recess or resect on any eye, because in a comitant strabismus, we are not wanting to or willing to accept incomitance in the post-op period. However, in these conditions, you have a pre-existing incomitance. You could go ahead and do larger than what you expect are willing to do in comitant procedures. So supramaximal recess resect procedure, and you may be able to get good results. Particularly, it is helpful when there is medial rectus function, as the eye movements are retained in the post-op period. Now, this can be used or very useful if there is an aberrant regeneration of the lid or aberrant innervation of the lid from the medial rectus fibers, and in what is called an inverse Duan sign. Of course, not a very great name for this, but as you can see, when the patient, so the right, in the case of right third nerve palsy, when the patient adducts the involved eye or looks into the opposite gaze, there is a lid retraction that you can see. Now, this can be used if you operate the other eye, essentially causing fixation duress and limiting the movement or attempting to limit the movement of the normal eye, causing increased innervation to the peritic eye and particularly to the medial rectus, which allows the aberrant fibers to bring about correction of the ptosis. So in this patient, we did a supramaximal resect procedure of the contralateral eye. Now, remember, as we are looking for fixation duress and we are wanting to augment significantly the amount of innervation to the affected eye, the procedure done in the normal eye should be nearly as much as you would have planned for the affected eye to bring about an equal amount of correction. So this is one condition where even in the normal eye with normal motility, we are going to do a supramaximal procedure because you want that innervation to be significantly higher in the affected medial rectus to get the correction. So in this case, we were able to correct both the exotropia of the third nerve palsy along with the ptosis that was there. However, if your medial rectus is not significantly firing or contracting, you may have to look for other alternate procedures, which although do not give you great motility in the post-op period, but at least give you good primary gaze correction. So one of the procedures being the lateral rectus anchoring to the periosteum of the lateral orbital wall, along with the medial rectus resection. Now, in this patient, you can see that a fair amount of exotropia, a small amount of adduction was present. In the post-op period, we were able to get good horizontal correction with a large medial rectus resection along with the lateral rectus periosteal fixation. Of course, note we've lost the abduction that was there or whatever was there preoperatively, but the compromise was to be able to get us good primary gaze alignment. Also, we are able to get some amount of adduction, so convergence also improves. So it's useful in these conditions where there is some good medial rectus function. As contrast to in this case where we tried this procedure, you can see there's hardly any movement of the globe on attempted adduction. And so the post-op results, although better, but still rather disappointing. So there is a significantly large residual exotropia. Now, in these conditions where there is significant absence of medial rectus function, the alternative could be a globe fixation procedure in which we will anchor the globe to the periosteum of the medial orbital wall. And of course, multiple publications have come for this, and it was a very popular procedure at one time. And even now, I prefer, personally do prefer it in a significant number of indications, but Dr. Pradeep Sharma here described it from the DCR procedure. We described it again, we modified it and described it as a precurruncular procedure because I found it to be much faster. There are other alternatives like using the facial lata or orbital periosteal flaps. Just simply quickly running through the procedure, we open the conjunctiva skin junction and reach directly to the medial orbital wall periosteum, from where we pass non-absorbable 5O ethibond sutures. Then the medial rectus is exposed as conventionally we would for any rectus muscle procedure. A tunnel is made underneath the conjunctiva, deep underneath, and these sutures are brought out adjacent to the medial rectus where they are tied. And the eye is placed in slightly overcorrected positions to catch the modest amount of exodrift that can occur up to 1 to 3 months. So here you can see some of our post-op results. So this was a patient with right third nerve palsy. You can see great alignment in the post-op period. Of course, because you've anchored the globe, you do not have any significant abduction. So again, another patient, you can see good post-op alignment, but obviously no significant movement. So good primary gaze results. Very useful in patients who do not have significant vision.
Recording in progress.
Tend to get adjusted to the diplopia that they may have in horizontal gaze. I'll go on to quickly onto the last procedure that is currently the fad, I would say, the nasal transposition of the split lateral rectus. And again, while this was described way long back ago, we learned about it from Goki Gate from her very interesting publication in JAPOS. We modified that slightly because it was shown to giving less than optimal results. And of course, you could do an additional medial rectus plication or resection with this procedure, but we decided to modify it and add posterior fixation sutures. So this is the lateral rectus. It is split into two. The superior slip is passed from underneath the superior rectus superior oblique and brought adjacent to the medial rectus, where it is sutured, and we place another posterior fixation suture to augment the transposition. This is the inferior root, the inferior slip from underneath the inferior oblique, inferior rectus, again brought to the medial rectus side with a posterior fixation suture. I always do a posterior tenectomy of the superior oblique along with this. The advantage is that it, of course, reduces the abduction force of the superior oblique, the posterior fibers, as well as helps in the mobilization of these superior fibers, and it is easy to bring them medially. And the other important thing to note is you need to actually split this muscle way far back posteriorly, at least 15 millimeters or more, so that it goes from behind and wraps around the globe posteriorly and does not cause compression of the vortex veins or posterior choroid that may result in any exudation, exudative detachment, or any choroidal effusions in the post-op period. So this is again another patient that we did. You can see this is one of our earlier results. Again, very good alignment. You can see great alignment in the post-op period. We changed this. We realized that it was non-modifiable. So sometimes you could get surprises in the outcome. So we modified it, and we were able to make it an adjustable transposition procedure. The only modification was that instead of putting fixed sutures on the ipsilateral side, we did the crossing of these fibers. So the inferior slip was sutured superiorly, and the superior slip was sutured inferior to the medial rectus and placed on adjustables on the short tag noose. Operative adjustment was done to correct for both the mild vertical deviation that we could correct. Like in this case, you can see there is a little bit of hyper with the exo. By adjusting the two sutures intraoperatively, we were able to get a much better outcome than was possible in the fixed suture types. Again, in this case, you can see there was a hypotropia in the preoperative, which was adjusted and corrected for by the adjustment of each slips, giving us much better outcomes. If there are significant vertical deviations along with the exo, we've tried full tendon transposition from the opposite side. Like in this case, the lateral rectus, full lateral rectus was transposed from the inferior root onto the medial rectus side. And you can see great vertical correction also, although the horizontal was not as great. In this patient, there was hypotropia along with the exotropia, and the muscle full lateral rectus was transposed to the medial side from underneath the superior root. So underneath the superior rectus, superior oblique, along with the PT, posterior tenectomy of the superior oblique. Again, you can see great vertical correction, not so great horizontal correction, but as we've only touched one muscle, in many of these cases where it was required, we went in and did another procedure like a medial rectification. As I said, it's now become a very interesting surgery done from all over the world. And this world group published 3 very interesting publications where now we have better understood the effect of this procedure in different hands. So just to quickly conclude, there are a lot of management options for third nerve palsy. Look whether it's complete or incomplete, any aberrant regeneration that you can make use of. Of course, if the patient is willing for getting the other eye operated, which can sometimes be a challenge. Choose appropriate surgery. We can see the response can be graded for each surgery. The LR to MR, I would prefer whenever I have associated vertical deviations that I feel I can correct them in one muscle transpositions. And if it is a failed surgery, like a resurgery or the FDT is positive, that is the lateral rectus has gone into contracture, I do not feel that the LR can be transposed onto the medial side because it's too short and it will not be able to be mobilized to the medial side. I would still prefer a periosteal anchor, which is kind of a fail-safe surgery for me. So thank you very much for the opportunity, both from DOS and Dr. Subhash. Thank you very much.
Thank you, Dr. Rohit, for excellent talk. So we can move to the next speaker.
Professor Pradeep Sharma.
Yes. Dr. Bhalla sir.
Dr. Bhalla.
So Dr. Prasad sir, you can introduce Dr. Pradeep Sharma sir.
You have the slide here? Can
Yeah.
you give me the slide here?
Slide.
Although Dr. Pradeep Sharma needs no introduction.
That's true. That's
the
true.
world knows him.
Yeah.
For the
Dr. Pradeep
stromatologist he is,
Sharma
but-
is a
but yes.
world-renowned squint specialist, and he was my senior in RP Center, a 1-year senior. And I had a lot of interaction with him because my thesis was on the squint. So Dr. Pradeep Sharma also had a thesis on squint. So we used to have a lot of interaction on the squint these days. And it was a really, really very good time when we were together there. And then after that also, Dr. Pradeep Sharma. Dr. Daria, can you give me the slide? Because yes, Dr. Pradeep Sharma has been the professor of RP Center AIMS in squint unit. And he is now currently practicing in the Center for Sight, Delhi. And he's available there for his consultation and the surgeries. And he has done a lot of publication on his squint surgeries and his squint and many of the international journals, a lot of presentation on squint. I've seen him many of the events talking him. And so this is the slide I'll just talk about. He's currently working, as I said, in Center for Sight. He's a renowned ophthalmologist and pediatric and neuro-ophthalmologist. Overall experience is 40 years now. He's MBBS from AIMS and MD also from the AIMS. In 1982, he's passed out. And he is the member of National Academy of Medical Sciences India 1995, Fellow of National Academy of Medical Sciences India in 2007 also, Fellowship for Advanced Training in Strabismus in USA by International Strabismological Association 2001, Jules Stein Eye Institute and Wills Eye Hospital, Philadelphia. He specializes in pediatric ophthalmology and squint and neuro-ophthalmology. And as I said, the numerous publications, more than 200 scientific articles and national and international journals, and many chapters and the books he has written on squint. Over 200 scientific presentations, regional, national, and international conferences, and supervision of 75 MD ophthalmology thesis and 1 DM dissertation in neurology. So it's the dice with the Professor Pradeep Sharma. Please, go ahead with your presentation.
I think there is some problem here. It's system share. There's some problem. I think it's a new laptop and it is asking for from desktop doc. Is it going? No, it's not.
No, sir.
The desktop is files. Advanced files. Share open system preferences.
Any discussion in the meantime while sir is loading? Dr. Sihan, any comments to make? Or on we've been discussing this one?
Dr. Rohit, I have a question for you.
Yeah.
When-
We'll have Dr. Sihan make a comment.
Yeah. And, yes.
Sorry,
Sorry.
who is it?
So I can
Who
finish
would
my
you
question with
like
Dr.
to
Rohit. Yeah.
know?
Dr. Rohit, you had shown that very beautiful technique of the lateral actress transposition towards the medial side, and the query was like when you are transposing it towards the medial side, and what do you do about the medial rectus? That is one. Do you attach it with the medial rectus, or it's just on the globe itself? Would there be any benefit of attaching it with the medial rectus without dissecting?
Is it coming, by the way? Just
Yes,
Yes,
sir,
sir, yes, sir.
absolutely.
Yeah.
Yes, sir.
Please go ahead.
I'll quickly answer it and we'll
Yeah.
quickly move on, sir.
Yeah, carry on.
Yeah.
Great. Dr. Rajendra Prasad, I suture it onto the sclera adjacent to the medial rectus. And we usually do not prefer to suture transposed muscles to paralyzed muscles because they usually tend to spread out. So if we suture it to the medial rectus, then the medial rectus would tend to spread out. And like I said, that if there is a residual exo, it does give us the opportunity to do a medial rectus procedure like plication or something. So the medial rectus is left absolutely untouched, and the transposed slips are sutured onto the sclera right next to the insertion of the medial rectus. And that ensures that you do not damage the vascular supply of the medial rectus. And if you require one more muscle surgery, say to correct residual exo or vertical, you have an opportunity to do so. So great question. Thank you, Dr. Rajendra Prasad. Seeing that your excellent thesis in strabismus has given you great insights on strabismus. We'll go on to Dr. Pradeep Sharma and his wonderful, I'm sure, talk on myopic strabismus.
Thank you, Dr. Rajendra Prasad, Dr. Bhalla, Dr. Subhash for making this possible. I'll be talking on managing myopic strabismus. And as we see, I have no financial disclosures relevant to this talk. Myopia has been becoming more and more popular, especially after the pandemic. And I think there are various aspects of myopia that we are now dealing with. We'll be mostly talking today on myopic strabismus. And myopic strabismus comes in all shapes and sizes. The most common, of course, is the horizontal strabismus associated with myopia. It may be a congenital myopia with esotropia. So because myopes are having a lower near fixation, they tend to be having more of esotropia even in the congenital phase. The other common variety is the intermittent divergent strabismus, which becomes more oftener manifest for distance because of uncorrected myopia, because the vision is poor for distance. And so we need to correct them so that the IDS becomes controlled. The more relevant type is the high myopia with poor vision leading to sensory strabismus. Then the retinopathy of prematurity can also be resulting in strabismus and myopia together. Accommodation spasm induced myopia and esotropia, which is coming more and more because of the lockdowns, is something in children we have to be extra vigilant and correcting them. And then more specifically, the acquired myopic strabismus fixus, which may be in the form of esotropia, hypotropia complex, as the sagging eye or the heavy eye or the knobby eye as described by Joe Deemer. And rarely we also get exotropia, hypotropia complex. Special considerations which we have to make in strabismus surgery if they are myopes. One is measurement of deviation. There may be an induced prismatic effect because of the myopic correction in the spectacles that we have to make correction for. The other is the accommodative convergence relationship, which will be displaced because of myopia. Third aspect is the thin sclera that myopes have, and you may easily end up having a perforation if you're not careful, even with the spatulated needles. And the fourth is the orbital imaging, which may be required to assess what kind of surgery we need to do in these cases. Now, coming to this decentered glasses. Now, this is something which is a common problem, which is commonly missed, and a decentered glass induces prismatic effect, which may be the only problem to correct, and the esophoria may not be real. So as you can see, high plus lenses induce a base out or base in effect depending on ESO or EXO. The same way, high myopic glasses also induce a base in and base out effect. And this error becomes significant more than 20 prism diopters and for more than plus minus 5 diopters. Now see this example of this person. He's having a 70 prism diopters measured exotropia. His power of glasses was minus 15 diopters. So when I looked into the tables, I found that the target exotropia comes out to just 51 prism diopters that we need to make correction for. The surgical nomograms will have to be changed for these cases. As you know, the high myopes are also going to have larger axial length. So the myopic eyes also have lesser effect. So that also needs to be taken into account. As I said, full correction in myopes helps in controlling the distance deviation. So many of these divergence excess may be corrected because of that. Pseudomyopia or induced myopia because of too much of accommodation near work is coming up more commonly nowadays. This is the acute esotropia. This needs a full cycloplegic refraction to relax the accommodation, may need cycloplegia for some prolonged times along with bifocals in some of these cases. Prematurity and myopia is itself another problem which may be there. But the more problem which usually balks us is the deviated muscle path or presenting as lateral rectus paralysis. It's not a true paralysis. It's actually a displaced pulley which causes the lateral rectus to be malfunctioning. So myopic strabismus fixus is a problem of deviated muscle path. And if you do a coronal CT scan, you will see that the superior rectus has got a nasal displace and the lateral rectus has been displaced in downwards. So there is an obtuse, large obtuse angle between the superior rectus and the lateral rectus. Myopes tend to have superior rectus, lateral rectus, tenons or the septum between them very weak, and that gets bulged out by the high myopia, and that causes a problem which we need to correct by a surgery, which is loop myopexy. Several procedures have been described over the literature, especially highlighted by Yokoyama in 2000, and then there are several variations of that. Remember that it can be a sagging eye or a heavy eye syndrome. You can see these in more details. Remember that if there is a higher myopia, it leads to a heavy eye syndrome, and there is an inferior nasal shift of the lateral rectus also, whereas in sagging eye, there is an inferior rectus only in the temporal direction. So, and there is a knobby eye, which is because of very high myopia, 20 diopters or more, and this leads to a displacement problem of the globe, which may not be easily corrected because the orbit is shallow for these eyes. Now, myopic strabismus fixus, which has a convergence like this kind of 90 plus esotropia, really balks you. But if you see the coronal CT images, you can see that the lateral rectus is in the inferior compartment and the superior rectus is in the nasal compartment. What you need to do is basically bridge these two by loop myopexy, and this is a post-op result in addition to the MR recession whenever it is tight. So this is a short video which is showing you how the surgery is done. So you see the superior rectus has been hooked 8 millimeters from the insertion. Non-absorbable 5-0 ethibond suture is passed.
Could the others mute?
Get this muscle displaced, marking on the superior temporal quadrant. Then again a bite is taken into this superior rectus. This is the muscle sclera muscle bite, so that the superior rectus gets displaced in the superior temporal quadrant. Now the lateral rectus also needs to be pulled up, and the ethibond sutures are now taking a bite in the lateral rectus. And as you can see, we will be pulling the muscle lateral rectus up. And this is just using the 5-0 bond. We are not using any silicone bands or any tubes, which adds to the discomfiture of the shallow orbits.
Dr. Bhalla, keep yourself mute, please.
Admin, could you
Now,
mute
this is how the
everybody else?
myopexy will
Everyone else,
result in the bridging of the superior rectus and the lateral rectus, and
Everyone
solves
else.
the problem that we were having of myopic strabismus fixus. Large esotropias corrected very nicely. Medial rectus recession may only be done in cases where there is a tight medial rectus. Now, in this children, when we have many a times the medial rectus is not tight, and we can just do a bilateral superior rectus loop myopexy without MR recession, and you can see excellent results like in these two brothers who had this, and this is another sibling which had the deviation. So no more myopic about myopic strabismus. We need to correct these problems in our mind first so that we can resolve these issues. And these are the takeaway points
I'll do
I
that.
would like to say.
Parishit, I have the list of the
Thank you
instructors.
very much for the patience.
I have the list of the instructors. I'll share it with you right away.
Dr. Bhalla, please.
I don't have the register of the delegates.
Dr.
Delegates
Bhalla,
वाला नहीं है मेरे पास. वो
Dr. Bhalla, mute
कल आ
yourself.
जाएगा. शायद पल्लवी के पास होगा.
Hello.
Dr. Bhalla. Dr. Bhalla.
Admin, could you please mute everybody
Mute
else during the
yourself.
presentation?
Dr. Bhalla.
Admin, is there anybody?
Sit there. Broadcast people. Hello. Is there any from the broadcast? Hello. Dr. Bhalla, can you hear? Dr. Bhalla.
And even that can be then
Dr.
shared.
Bhalla.
People know.
Dr. Bhalla.
Yes, sir.
डिस्टर्ब कर रहे हैं बीच में आपका फोन आ रहा है बहुत ज्यादा उसमें
हाँ नहीं मैं
because throughout Dr. Pradeep Sharma's presentation was spoiled completely.
I think I was not muted. I'm so sorry.
Yeah, so we are
Okay.
So any questions or discussions on strabismic myopexy or eye myopia? Dr. Sian, any comments on this?
Thank you, Dr. Sharma. This was an excellent talk. What I would like to learn is when in a very high myopic patient, but who do not have a myopic strabismus, who had, some of them have stress forward esotropia or else. So when I do a recess resect surgery, I look with an ultrasound, and it is, I mean, in the office ultrasound with the B mode, and have a rough axial length, and then I make a calculation to find out the place of the equator. So I increase the amount of the recession that I do. So I would like to, you had the huge experience, and I would like to learn your approach in straightforward, let's say an esotropia, who is not a myopic strabismus. How do you change the amount of surgery that you do in a recess resect surgery? And if you do, how do you do it?
Right. So in cases in which there is a recess resect to be done, and as you're saying, there is no displacement of the muscle pulleys. So it's not a myopic strabismus as we say for the sagging eye or heavy eye syndrome, because in those cases, you will find that the surgery is not going to be yielding any results. A lateral rectus resection in a case of myopic strabismus is not really required. It just needs to be pulled up. So, but cases in which there is no displacement of the lateral rectus pulley, and it's just a plain recess resect that you are looking forward to. So two things have to be taken into account. One is, if the person is going to wear spectacle correction while measurement of the deviations, you have to account for the induced prismatic effect. As I showed you, that children who have large myopic corrections, they may have a induced prismatic effect, which needs to be taken into account of your nomograms. This is especially for recess and resect both. But for the axial length, it is mostly relevant to the recession part. The resection doesn't make a difference in the axial length. So when we are going to decide the amount of surgeries, and if you find that the axial length is large, so from the nomograms, you found that the 70 prism diopters becomes 51 prism diopters. So for the 51 prism diopters, let's say you calculate that you would like to do a 7.5 millimeter of lateral rectus recession. If there is a exo, or if there is an ESO, then the medial rectus recession of 5 and a lateral rectus resection of 7.5 you would be doing. So the resection component need not be changed. But for high myopes, you will have to be doing a little more recession. So you add 1 millimeter more for the axial length being large. So that is the thing that we will have to modify in our surgery. Yeah, I hope I'm clear. So the two aspects, one is the measurement point, the other is the surgical part, when the effect of the eyes, myopic eyes, yields lesser effect for each millimeter for recession, not for resections.
Yeah, thank you.
Can I ask a question?
Yes, Dr. Deepti, any comments before we, I think, move on to the last speaker?
Sir, I had one patient, not really high myope, maybe minus 2.5 to 3. She presented with esotropia. She said sudden onset, maybe recent onset, maybe T35. But over a period of, when I kept observing her over a period of next 6 months, she kept on progressing. And I did resect, but still, despite that, there was some amount of progression residual. I had given a bit of Botox. Any comment about this type of progressive esotropia? Not really, she was not high myope, sir. She was somewhere around -3 only. That was the max. So any better way in which I could have managed or waited for some more time? So any comment about this case?
You eliminated accommodative?
Yes, yes, sir.
Deep cycloplegia, because sometimes atropinized is necessary, because many of these may just be progressive and they may be difficult to pick up. I've had a child and 3 children now who are on atropine ointment for more than a year, because whenever I've tried to wean them off, they go back into their esotropia. So it's a challenge, of course. I mean, if you have that is the other thing. That is the most important, I would say, a variable factor that would progressively increase a recent onset acquired esotropia. Sir, any other comments?
Yeah, I think that's right. That one is that you have to take care of the accommodation which may be doing it. And if there is no such thing, then you, I think, should look into, if there is a situation like that, do a coronal CT.
Yes, sir.
Because we have seen that cases which have displacement of the lateral rectus downwards, the surgical results are not effective. So I think there are some good publications from Joe Deemer's work that after the resection being done, those cases which did not yield results, he had pulled up the resected lateral rectus up, and that itself worked. So I mean, that is something which you have to be taken into account, that if it is the displacement which is causing, it's the pulley which is causing the lateral rectus to become inefficient. So whatever amount of resection you do will not yield results. It will only cause, sometimes we will see that also, that the eye is becoming more hypotropic after the surgery rather than getting a correction for the divergent strabismus.
Noted.
So I think
Dr. Bhalla, could you introduce our last speaker?
Yeah, last speaker.
Yeah, I think so. The last speaker of the day, Professor Subhash Datia. I'll just. Yeah. Professor Subhash Datia did his MBBS from Rohtak Medical College, and after that he did his MD Ophthalmology from RP Center AIMS. He also did his senior residency from Guru Nanak Eye Center, MAMC, and after a brief period as a pool officer at Safdarjung Hospital, he subsequently joined as an assistant professor at Guru Nanak Eye Center, MAMC, where he is currently working as director professor of ophthalmology. He is active member of DOS. He has been executive member, library officer, secretary, and vice president of DOS, and currently he has been executive member, joint secretary, and secretary also of Strabismological Society of India, and he has been chief editor of Indian Journal of Strabismology and Pediatric Ophthalmology. He is also member of Asia Pacific Society of Strabismus and Pediatric Ophthalmology and member of International Strabismus Association. He is active member of AIUS. He has written about 100 publications to his credit in various national and international journals and is a very popular guest speaker at various regional, national, and international conferences in various capacities. Dr. Professor Subhash Dadia is going to talk on diagnosis and management of monoocular elevation deficiency. Dr. Subhash Dadia, please.
For excellent introduction. Sure. So, very good evening to one and all. I will be speaking on diagnosis and management of monoocular elevation deficit. Basically, it is defined as inability to elevate paretic eye from any position of gaze, provided ductions are normal in all other positions of gaze. It is paresis of superior rectus and inferior oblique with ptosis, or it may be due to long-standing palsy of superior rectus. Initial term was double elevator palsy, which was coined by Dunlop. It may be congenital or acquired. It may be paretic or restrictive, or it may be supranuclear. Monoocular elevation deficiency is more accurate term, as paralysis of both muscles independently and supranuclear lesion can lead to impaired unilateral upgaze palsy. In congenital cases, it may be due to supranuclear defects. It may be due to SR paresis, IR restriction, neonatal hypoxia. In acquired cases, it may be due to CVS diseases, midbrain tumors, pineocytoma, acoustic neuroma, and metastatic tumors, sarcoidosis, and infections like cysticercosis. They are also causes of acquired MED. So it has been classified into type 1, type 2, and type 3. In type 1, inferior rectus restriction is a prominent feature. In type 2, it is mainly elevator weakness, and type 3 is combined. So clinically, the patient presents with limitation of elevation above midline, both in abduction and adduction. There is hypotropia of involved eye. There is presence of ptosis and pseudotosis. Usually, the patient adopts a chin elevation position. In most of the cases, it is unilateral. Marcus Gunn jaw winking phenomena is seen in approximately 25% of the patients. These are the clinical photographs of some of the patients with MED. So for diagnosis, it is very important to ask history of onset. If sequence of events is not clear, then presence of amblyopia suggests congenital etiology. We must look for previous photographs, and in acquired cases, we must ask for history of neurological symptoms, past medical history, and general systemic symptoms. In type 1 MED or DEP, there is forced duction test is positive. FGT is normal, normal skates are there. There is deeper lower lid folds, and Bell's phenomena is negative. In type 2 MED or DEP, the FDT is negative. There is reduced saccadic velocities. There is reduced force generation, and intact Bell's and absent skates above midline suggest supranuclear lesions. It is very important to differentiate acquired MED or DEP from congenital MED. In acquired MED or DEP, there is acute acquired diplopia in upgaze. There are neurological symptoms. Ptosis is usually not a prominent feature in cases of acquired MED, and in acquired MED is usually associated with pupillary abnormalities and convergence weakness. Bell's phenomena is usually present, and patient often assumes chin up head position. So this is clinical photograph of a patient. She is 20-old-year female with traumatic MED, and FDT was suggestive of tight IR. Then 35-year-old male with right was case of right acquired MED. This was known case of sarcoidosis with high ACE level, which was sent to us for evaluation, and there was hilar lymphadenopathy in HRCT chest. Then this patient, 20-old-year-old female patient, which was resident of Delhi, presented with chief complaint of diplopia in upgaze since 1 month. And when we do the imaging, inferior rectus was thickened and there was presence of cystic lesion within the inferior rectus, and there was hyper-intense echogenicity within the cyst. And this was case of acquired MED to cysticercosis. Imaging was done, which was reconfirmed on MRI. And after managing this patient with oral albendazole and steroids, the patient was orthophoric and elevation limitation also got resolved. This is the post-treatment photograph of the patient. Then it is very important to differentiate congenital MED from acquired MED. The acquired MED can be arise at any age. The onset in congenital MED is at birth. The clinical features, strabismus and ptosis, they are the prominent feature in congenital MED, while in acquired MED, acute onset diplopia in primary and upgaze is the prominent feature, and ptosis is usually not a prominent feature. Systemic causes are there in acquired MED, while they are not in congenital MED, and sensory adaptation is amblyopia suppression, which is common in congenital, while diplopia is common in acquired MED. So differential diagnosis for congenital MED could be Brown syndrome, vertical veins, congenital fibrosis of inferior rectus, congenital absence of superior rectus and inferior oblique, abnormal insertion of inferior rectus or superior divisional third nerve palsy. While differential diagnosis for acquired MED are thyroid orbitopathy, myasthenia gravis, orbital fracture, third nerve palsy, orbital cellulitis, orbital inflammatory disease, and cerebral tumors. This was a patient of ocular myasthenia gravis, which presented like acquired MED. Then indications for surgery: if there is significant abnormal head position in primary position, if there is presence of significant vertical deviation in primary position, if there is contracted binocular fields, diplopia in primary gaze, these are the indications for surgery. In most of the patients, only observation is required because patient can maintain orthophoria with limited head changes, and treatment of MED or DEP is surgical and only surgical. The goals of surgery are to achieve cosmetically acceptable position in primary position, to increase the field of binocular single vision, and it is very important to tell that surgery will not cure the MED, and it is very important to tell to the patient that more than one surgery is required, and most of these patients, they report to the oculoplasty persons with the complaint of ptosis, so they have to be told that strabismus surgery will be done first and ptosis surgery will be done later on. So various surgical procedures has been described for this MED. Optimal surgical treatment for DEP remains controversial, and it should be according to type of DEP. In type 1 MED or DEP, recession of the involved inferior rectus is the treatment of choice. In type 2 MED, NEFS procedure is well established, commonly practiced procedure, but it has drawbacks. Patient loses some abduction and reduction, and effectivity decreases if deviation is more than 25 prism diopter. These are the steps of NEFS procedure. Then modified NEFS procedure, if there is MED is associated with horizontal deviation, then this modified NEFS procedure has been documented by us, which is very effective in cases of MED with horizontal deviation, because most of the patients, they don't want surgery in the normal fellow eye. So we can do this modified NEFS procedure in cases of MED which is associated with the horizontal deviation. Vertical resection and recession have been also tried in cases of MED from our center. Then this esotoniectomy and vertical muscle recessions have been found to be effective modality in congenital MED by Chinese studies. Then Sneer et al. Recommends NEFS procedure with posterior fixation sutures. These are the clinical photographs, preoperative photograph of a patient of MED. This is the postoperative photograph of same patient. Then this is the preoperative photograph of another patient. This is postoperative photograph of same patient after surgery. Pre-op photograph of another patient. Postoperative photograph of the same patient. This is 9-gauge photograph of patient of MED. This is postoperative photograph. Then again, preoperative photograph. This is postoperative photograph. Preoperative photograph of another case of MED. This is post-operative photograph. And this final slide is very old slide. Basically, this was case of congenital MED, and this is pre-operative photograph. And this photograph is after squint surgery and finally after the ptosis sling surgery. Very good alignment. So when to intervene for ptosis, you should wait minimum of 6 months after squint surgery, because magnitude for vertical correction increases with time following NEPS procedure. Thank you very much.
Thank you. Thank you. Thank you very much, Professor Dadia, for the quick and fast presentation. And he has taken care of the very short of time we are already into. And very quickly, we'll go ahead with 1 or 2 questions. Professor Rohit Saxena, any comment on Dr. Dadia's presentation?
No, excellent presentation. Dr. Dadia has covered essentially everything. And he has given a very nice algorithmic approach, how we need to identify the primary cause, whether it's acquired, whether there is any orbital cause, because acquired causes, you need to image, you need to identify the cause, make sure, and your decision-making on the force reduction test as a diagnostic test to understand how you're going to manage. So Dr. Sehan, I think, has an experience also for Botox. So I'm sure that would be interesting to listen to.
Thank you, Rohit. Well, actually, I don't have any experience with Botox in MEDs, but my experience that we have recently reported at the APOS meeting is that in those who had supranuclear monocular elevation deficiency, sound eye surgery gave very satisfactory results. So in those, I mean, this was just a couple of cases, and what I have done in those cases was a large superior rectus recession in combination with a modest inferior oblique anterior position in the sound eye. So both the pseudotosis and the vertical deviation, which was in one of the cases exceeding 30 perisome diopters, it was 34, and in one of them it was 22 something. And they both gave very stable and good long-term results. So I was doing transpositions before, but as Dr. Dadia nicely mentioned, that the transposition surgery in time may have caused some problems on abduction problems and so on. And I also had some patients who later in life developed DVDs and so on, and I had to reoperate and so on. But this innervational surgery, well, although the numbers are not so high, gave excellent results. So I think previously the superior rectus recession was studied, but combining with modest inferior oblique anterior position worked pretty well.
Basically,
yeah, excellent point. Yeah.
In our setting, only problem is most of the patients, they don't give consent for the surgery in the normal eye.
Yeah,
so
that's
whatever you have to do has to be done in the diseased eye. So that is the basic problem.
Correct.
And recently, when this some modified Nishida's procedure has also been described in some cases of the MED with the successful results.
Quite right.
Right.
Do we have time? May I ask a question to Dr. Saxena? Because we skipped to short.
Yeah, you can ask two questions.
Yeah, just for the Turner palsy, I just, as a quick comment, for the supramaximal recessor sex surgery, we were using it with traction sutures before, and which was remaining in place for 6 weeks, which was quite unpleasant for the patient actually. But the result, for the orbital fibrosis element, it is very useful. And recently we have started to use toxin in place of traction sutures with a supramaximal recession in combination with botulinum toxin and with a supramaximal resection. So, you know, and resections doesn't work well in Turner palsy, but when you do it in an overcorrection and when you provide an overcorrection at the early period, the result is quite long term. And so this was just a comment. But my question, especially for you, is that with the lateral rectus split surgery, my main concern is the vision-threatening complications, which is in the multicentric study, as you mentioned, it is as high as 20%, which is a too high percentage for a strabismus surgery. So, and this you had a lot of experience with the surgery. So what is your experience with the retinal problems that you had, and how long did it last? And did you have any permanent problems with those? And of course, also I would like to learn how you handle those cases on their reactions postoperatively when they have problems with the retina. Yeah.
So I think sir would remember, I think one case had significant choroidal effusion with, I think, exudative detachment. She unfortunately did not recover her vision completely, although significant recovery was possible. Thankfully, after that, we have modified our surgery. And as I mentioned, and I showed that imaging also, we ensure that the split of the lateral rectus is more than 15 millimeters from its insertion.
20, so maybe 20.
That the muscle then, the split muscle actually then wraps around from behind the globe instead of it coming anteriorly, with the risk of compression of the vortex vein. So that one, and secondly, the posterior tenectomy of the superior oblique, which allows the muscle to slip nasally. And the other thing is, of course, as I mentioned, that if the post-duction test is positive, or even if it's moderately or more tight, then I would not consider doing this procedure, because that would mean that you're actually pulling the muscle a lot, and that is pressing on the posterior part of the globe, with the possible risk of compromise of the venous outflow of the choroid and the retina. So that is, after that, I have not, touch wood, had any significant complications. That patient was managed with steroids. One or two patients have had mild uveitis in the post-op period, again managed with, usually with topical steroids, and I don't even remember having to now ever give systemic steroids to any of these patients. But yes, a potential vision-threatening risk is there in these patients. But I mean, the other thing is, I mean, of course, again, never had to do it. But the other thing would be that you could easily, if it's unadjustable, you could easily release the muscle suture slightly, so that you may get a little under correction, but you will release the pull. And if you've put in posterior fixation sutures, just simply go and release the posterior fixation sutures. Again, a little under correction, but it will help to relieve the compression at the posterior part of the retina, which may be one of the major causes for this problem.
Thank you.
Yeah, I think it can be undone, and you have to be careful in the first post-op day. So that case which we had in the of the serous retinopathy, because of that, we released the sutures, and she is now back with 6/6 vision. There was no problem later on. So yeah, you have to be careful in the post-op period whenever you're doing these cases, and you have to be liberal in your splitting of the lateral rectus to at least 20 millimeters or more.
I think, so any other questions from any clarification or any comment? Dr. Chaudhary, Dr. Alkesh, you want to put any comment? Because actually
Christmas after retinal surgeries.
Retinal surgery, because we keep on seeing many of the cases after the band and buccal surgery. Many of these patients, they report with this squint and strabismus with
Dr. Alkesh, you are mute. Of course, I'm sure you will have experiences of retinal problems post-strabismus. I think it cuts both ways.
Yeah.
Alkesh, you're mute.
Dr. Alkesh, unmute yourself.
Unmute.
I know you are the only retina person here.
Yeah.
Maybe little...
I think you can hear me now.
Yeah.
I remember when we were doing fellowship, when squint people couldn't search muscle, then we used to go and search the muscle for them.
That's good. That is the biggest comment of today, I think. Retina surgeon helping the squint surgeon in doing the squint surgery.
That's interesting. Where was it?
I was in Shankar Nethralaya.
Okay.
So I think it was a great session.
Definitely, and one thing more, we were managing a lot of the scleral perforation, like suture going inside, doing perforation, suturing, passing through, the leading to retinal detachment, managing those cases.
True. That is one of the complications the squint surgeon may face quite often. And especially as Dr. Pradeep Sharma has said, like in these myopic cases, your sclera is very thin. So putting these sutures on the sclera would be very difficult, I think. Dr. Pradeep Sharma, you have any experience of such situation? Handling these myopic cases?
Yeah, I mean, myopic cases, we sometimes see that even though you're being careful, you may be just getting the black pigment. But usually you need to monitor them. We don't necessarily have to cryo them unless there is a frank vitreous ooze. Otherwise, you can just suture it and manage some pigment which may be showing up. Doesn't usually cause problem. For a follow-up of these cases is important. And if need be, you can do a laser even post-op.
Yeah, that's right.
Yeah, like we are doing passing suture for putting buckles, and those sutures are very, very deep. Only thing, while passing suture through the sclera, you should always see the needle. The needle should always be visible. If you're losing any track of the needle, when it's not visible, come out immediately. And like laser, sometimes you're not able to, you can do cryo also in those areas. So cryo is going to because immediately retina is not detached. So if you do cryo, it is going to help you, because sometimes it is a posterior. Immediately you can't go inside, do laser. So best thing is do the cryo.
Right. True. Thank you. And I think now we'll stop the session now. And this was a very, very great session. And I really thank you and appreciate all the speakers. And my pranam to Dr. Pradeep Sharma. He has been our guru, and always learned from him lot of things. And very, very vibrant Rohit. And Rohit is already making his very big name in squint strabismology now in worldwide. And Professor Dadia, very, very good friend, and he's doing a lot of work in GNEC and looking after the whole unit of the squint and doing very great work. And my special thanks to Deepti Joshi, who has joined us and given us such a beautiful talk. And our international faculty, Dr. Sehan, and really great. And we really appreciate you joined us this evening. And Dr. Amila from Sri Lanka. Great. Thank you, Dr. Amila, for joining us and giving us an honor for our Indian ophthalmologist being with us here in this beautiful evening. And I thank all our DOS executive and the people, those who have worked for this session. And thank you very much, all of you. And I thank our guests and those audience who joined us this evening. And we'll definitely see you in the next upcoming webinar very soon. And good night, and thank you, everyone. Thank you very much.
Thank you.
Thank you.
Thank you.
Thanks a lot.
Good night.
Namaste.
Thank you.
Namaste. Namaste.